Okay, so I start again to give everybody a warm welcome from Munich here. I thank Joseph Haddad for his kind words, and my particular thank is to Nestle, who made this evening possible, and these technicians who helped us struggling with the technique. So hopefully we will survive this evening with no big technical problems. So my topic tonight is food allergy, and particularly, of course, being a gastroenterologist, food allergy in the GI tract. So this is really a very difficult one. As you will see in the cases I will present, there's a very high risk of both over and underdiagnosing. And of course, both is not good for the child. And it's particularly difficult if there is no specific IgE testing. So I will put some attention on these subgroup of food allergies. And then, of course, in the last part, I try to help you to find your way through this, through the management, the diagnosis, and the treatment. Well, if you ask on a population basis, adult people, about a third will tell you that they have some kind of uncommon or unpleasant symptoms after ingestion of specific food. And this percentage goes even higher if you ask adults with irritable bowel syndrome. If you ask them specifically for food allergies, they self-report about 13%. However, if you then apply very rigid diagnostic criteria, you end up in a prevalence between, let's say, 2 to 8%, so but definitely below 10%, and there is a higher percentage in children compared to adults. But looking at this wide range already tells you that this is only an estimate, and we really don't know the real prevalence because of the difficulty with the diagnosis. Here you can see the point prevalence every year in a large German population-based cohort. These were almost 6,000 children who have been followed from birth until 15 years of age, and every year we looked at the prevalence of the 4 different allergic diseases. And you can see at 1 year of age, the leading one is atopic dermatitis with about 11%, and food allergy is the second one with around 4%. In both of them, if these children grow older, the prevalence decreases and ending around 4% or 3% to 3% by 15 years of age. On the contrary, the respiratory allergies increase over the year. So it's a completely different picture depending on the age in this population. We also looked in this cohort on comorbidities. So the risk of having one or more other allergic diseases by having one. And if you look at the purple circles, these are the ones with atopic dermatitis, but you can see the majority of those have only atopic dermatitis and not 1 or 2 of the other diseases. But in the blue circle, you see the children who had food allergy. And having food allergy, your risk to develop later another allergy like asthma or allergic rhinitis or eczema is much higher. So these are high-risk children for comorbidities. The main elucidating foods in our region and also in the Middle East, it's the leading one is cow's milk, and then followed by Henseck and wheat, soy, and then later nuts and fish. This may differ in different regions of the world. For instance, in Asia, rice is one of the top foods. But basically, you can have an allergic reaction to many, almost every food or the protein in different foods. Now I will start and give you 5 cases. And after each case, I want to have your opinion to see whether this child, what do you think, is a case of food allergy or no food allergy. So I start with Paul. Paul is 7 months when we saw him, and he's a healthy, thriving baby. And he's still on breastfeeding with some solids, vegetables, potatoes, and meat. So when the mother started and gave him some cereals with milk, he started coughing and refusing the feeds, and the mother thought he had choking, and she tried again, but then Paul started vomiting. He turned red in his face and coughing again, and with breathing difficulties. So the mother brought him to the nearby hospital, to the emergency, and by that he had developed urticaria in the face, and he had already really problems with breathing. So a very severe acute reaction. So what do you think? Do you think that Paul has milk allergy? So if you think yes, push 1, 2, very likely, 3, unlikely, and no is 4. So please vote. You have 5 seconds. So does this technical thing work, or do we have a problem with the voting? I cannot see any result. No, it's not working. So obviously this voting does not work. So make up then your mind. Maybe you take a piece of paper and a pen and write down the number for Paul, whether you think it's a yes, a very likely, unlikely, or no. And then we come back later to these cases, and I give you the result, and then you can see whether they were right, you were right or wrong. Now the next patient is Carla. Carla is 5 months, and she was a colicky baby, and she was exclusively breastfed until 2.5 months, and then the mother started to give once in a while a formula, and so mixed feeding. 2 weeks later, she had an episode of vomiting and severe diarrhea, and then she refused the bottle, and the pediatrician saw her and diagnosed, she most likely has an acute gastroenteritis, and recommended the mother to go back on full breastfeeding, and Carla recovered very quickly. So 2 months later, again, almost like Paul, she had her first cereal with milk, and 2 hours later, she started vomiting, turned pale and lethargic. So the mother called the ambulance. She was brought to ICU, and when she arrived, she had severe metabolic acidosis. So again, what do you think? Does Carla has milk allergy? Yes, very likely, unlikely, or no? Please write down Carla 1 to 4. So it tells me that they cannot vote for some reason. Doesn't matter. We go now to the next case, Ali. Ali was 7 months when we saw him, and he had a history of eczema, severe eczema, and at 4 months he also developed an eczema hepaticum, was treated with acyclovir and antibiotics. Then the mother, because of the severe eczema, spent 6 weeks in a special hospital for allergic persons, and the mother started an exclusion diet. But things did not improve, and when we saw her, he was still exclusively breastfed, and you can see now how he looked like, really very severe eczema, the head, but also the trunk, the legs. And again, the question to you, in this fully breastfed baby, do you think that he has milk allergy? Okay, I hope you made your guess. Now look again, look at the pictures of this baby. And I ask you a next question. If you keep the picture in mind, and my question to you is, does Ali have malnutrition? Yes or no? What do you think, looking at this boy? I don't know what you answered, but I assume some of you answered with no, because he would look still quite chubby. But when we were surprised when we plotted his percentiles, so this first point when he was in hospital with a eczema hepaticum, and you can see within 3 months that he dropped not only with the weight, but also dropped in the percentiles for length and even head circumference. So because of the drop in length, he still looked appropriate and not too skinny, but this is a severe malnutrition with dropping length and head circumference. Now we were even more surprised. We took blood, we admitted him, of course, and then we looked at his blood on the day of admittance. And you can see he had severe leukocytosis with 52,000 and 28,000 eosinophils. So a third of all leukocytes were eosinophils. He had hypoalbuminemia. He had very low immunoglobulins, but sky-high IgE, so 11,000. No inflammation signs. And most likely, because he was dehydrated, his uric acid was high. So very dramatic lab values. Now again, the question to you is, after seeing this malnutrition, after seeing his lab values, would you consider milk allergy in him? Yes, very likely, unlikely. Did you change your mind after seeing the lab values? But you can see, and I guess you are struggling with the answers, and I did the same. And I think these cases show you how difficult this is and how many differential diagnoses come up in your mind looking at these children. Now the next one, Anna, is a bit easier. Anna is a case which most of you have seen or will see on a regularly basis. So Anna was a fully breastfed, thriving baby. She was a frequent spitter, but otherwise no problems. But then the mother noticed blood in his diapers, and it changed from medium and then sometimes only a little, and then some of the diapers were quite bloody. So this was going on for 3 days. The mother went to the pediatrician, and again the question to you is, do you think that this fully breastfed or exclusively breastfed baby has cow's milk allergy? Okay, keep in mind, write down, we come back to that later. Now the last case is Baran. Baran is a 3-year-old. He has a chromosomal anomaly and was retarded. When he was a baby, he had received PPI for 4 months because of GERD symptoms. And then he was doing fine, but at 3 years, he started to complain about pain. He refused solids and he developed severe constipation, and 2 times the mother noticed blood on the stools. When I looked at him, he had very thickened skin around his anus. This is his anus on the picture. It almost looked like elephant skin. So would you consider milk allergy in this boy? Okay, so these were the 5 cases. Now, is there any marker, any clinical lab or whatever diagnostic marker which help us to prove or disprove cow's milk allergy in Paul, Carla, Ali, Anna, or Baran? What do you think? Is there anything? Again, make up your mind. And there are different options. Does the history help us? A clinical examination, any blood test, stool test, the microbiome, or maybe the metabolome, skin testing, endoscopy with histopathologies, or exclusion and challenge with allergens? Is anything which accurately tells us whether the 5 children have or have not cow's milk allergy? And the answer is a clear no. It could helpful in some, but not be in others. So, and this is a problem. We do not have a single test like in celiac disease, the transglutaminase antibodies. That's a very nice test. It tells us immediately, oh, the celiac is very, very likely or very unlikely, depending on positive or negative. But we do not have such a thing in food allergy. And why is that? Because we have a huge, huge variety and clinical picture of food allergy. It depends on age, but it can be on the skin, it can be unspecific symptoms like crying, spitting, constipation, failure to thrive, or it also can be endoscopic, different endoscopic finding. So we have a broad picture, and we also have different pathomechanisms. And this is a reason why we do not, and most likely will never have a single test to tell us food allergy, yes or no. And that's why diagnosis is really difficult. Now, food allergy, the definition is very clear. The definition, it must be an adverse reaction to protein in food. So it must be the protein targeted. It must be by an immunological mechanism. So that's food allergy. And if there is an immune mediated, there's also a non-immune mediated. And there are several ones which actually may have the same clinical picture, like lactose intolerance can also have diarrhea and abdominal pain and bloating, and you can have diarrhea and pain and bloating in food allergy. So the clinical picture may be very similar, but the mechanisms are different. And within the group of food allergy, we have IgE mediated ones, we have non-IgE mediated ones, we have mixed mechanisms and cell mediated. So again, because of these different mechanisms, this also is very difficult to develop a diagnostic marker or diagnostic test. Oops, it stopped here. I'm stuck here. Okay. Now let's look in milk. And milk is okay, let's look what kind of protein is in milk. So in milk, we have protein, lactose, and fat. But as we said, if it comes to allergy, only the protein counts. So what do we have in protein? We have the casein fraction and we have the whey fraction, both in mother's milk and also in cow's milk and in cow's milk formula. And within these two main fractions, you have different peptides and subfractions where a baby or an adult or whoever can be allergic to. So you can be either allergic to the peptides or proteins in the casein or in the whey or both. And again, that makes diagnostic also on the blood level very difficult. And then we have some proteins like beta-lactoglobulin. This is a protein in the whey fraction of cow's milk, which you do not find in human milk. However, so the mother is not producing beta-lactoglobulin. But if the mother is eating or drinking milk or eating yogurt, then you find little amounts and traces in human milk. So everything what the mother is eating, you find in little amounts in human milk. So you may find gluten and egg protein. So everything is in the milk, not in every mother and not on a daily basis, but in general, you find these traces. And most likely this is done by nature in order to develop tolerance. But this can be a problem in very sensitized children that they may react to the small amounts in mother's milk. And this is the reason why children who are exclusively breastfed may develop allergy against soy or cow's milk, although they have never drinking or eaten soy or cow's milk protein, because of this leakage into their mother's milk. However, in general, an exclusively breastfed baby is much less likely to develop cow's milk allergy, about only 10/10 of a baby who is formula fed. So it may occur, but it is rarely, and the manifestation is more mild in general. It's not moving. Okay. So this picture, again, just to remind you that cow's milk protein allergy. So it's a protein is a eliciting content of milk, has absolutely nothing to do with lactose intolerance, which is not an allergy. It's really a lack of enzyme to split lactose, so lactase deficiency. So what makes a protein? It's a bit slow. What does a protein make an allergen? It's not showing up here. Something is wrong here. It's not coming up. So here you see a protein, and then within this protein can have two bindings or epitopes to become or to make it to an epitope, an allergic epitope. So one in green, you see what we call the linear epitopes, and these are defined by the sequence of the amino acids. And in order to get rid of these epitopes, you need splitting, you need hydrolyzation between these amino acids, and then you can get rid of the epitope. And in red, it's not the amino acid sequence, it's a steric, it's a conformation where the immune cells log on, or the antibodies. And these conformational epitopes can be destroyed by heating. And this is why children with cow's milk allergy, many of them tolerated highly heated milk where these conformational epitopes are destroyed. While if you are allergic to a linear epitope, this cannot be destroyed by heating. It's heat resistant. Now, from the clinical point of view, you can characterize food allergy or describe the characteristics at the age of manifestation. Is this a baby, a school-age child, or an adult? You distinguish early and late symptoms. So after ingestion, when does it appear? Then the location within the GI tract. It can happen from the mouth to the anus at different levels, and also in extraintestinal manifestation on the skin, eye, nose, lung, or anaphylaxis. And then we distinguish two phenotypes, the ones with transient allergy, meaning that the children grow out of this, and this is often the case for cow's milk and also for egg, while other like peanut are often persistent through all life. So these are the different types. And then the distinction between IgE mediated and non-IgE mediated. So this term tells you only that this particularly child with an allergy against a specific food, let's say milk or egg, is positive for specific IgE against this food, either in the blood test or in the skin prick test. So having a food allergy and only being positive or negative determines whether the clinical term, whether it's an IgE mediated or non-IgE mediated food allergy. So the tests determine the type of allergy, but not the clinical symptoms. So both can be very severe and both can appear early. So they cannot be clearly distinguished on the history or on manifestations. And another difficulties is that some babies with allergy are specific IgE negative, but then over the years may switch to IgE positivity. So you may change your phenotype. Again, that makes it a bit difficult. In general, you can remember if it comes to the skin, it's more likely that this allergy is positive for specific IgE. If it comes to the gut with a different immune system in the gut, it's more likely that your skin prick test or your blood test is negative. And within the GI tract, we have allergic diseases which are very likely to be IgE positive, and this is the GI early reactions and the oral allergy syndrome, which is associated with allergic rhinitis. In the middle part, you have the diseases which we call eosinophilic diseases, and this can be in the esophagus, in the stomach, in the small or large bowel, and they can be positive or negative for a specific IgE. And then in the bottom part, you have those manifestations which are most likely IgE negative, and this is the food protein-induced enterocolitis syndrome, or FPIES, the proctocolitis, and the enteropathy, which is really a severe enteropathy and it looks similar to celiac disease. If it comes to symptoms, we have two big groups. One manifestation is dysmotility, and dysmotility can be in the wrong direction, meaning vomiting, regurgitation. It can be too slow, like delayed gastric emptying or constipation. It can be too rapid, then you have diarrhea, and it can have spasm, then you have pain. So it's pure dysmotility. Or you have inflammation with ulceration, with bleeding, with protein loss, malabsorption, mucosal lesion, and then you have refusal to feed and failure to thrive. Or you may have a combination of dysmotility and inflammation. And of course, then you always can have anaphylaxis with systemic reactions. Now, if you remember these 5 cases I presented, how do you come now to a correct diagnosis to decide, is this a case of food allergy or milk allergy, or is this something else? And as you said, we had 2 of the children were exclusively breastfed, 2 had, and the other 1 were already on milk-containing foods. And in order to help you, the societies, different societies develop guidelines on the evidence what we have, and then we have from the World Allergy Organization, the JACMA guidelines, but they are very much focusing on IgE positive allergy, so not that much on the GI tract, so more on skin. And then we have the ESPGHAN guidelines, which were as a very practical approach for diagnostic workup and management. And then more recently, a special guidelines on FPIES, on the definition and workup and all what we know about FPIES. We have one on anaphylaxis, and the most recent one published last year is a special guide dealing with exclusively breastfed infants with non-IgE GI manifestation or a GI allergy. So again, a very special subgroup. So if you need help, you can pull these. They are free, online, available, and they may help you. So what do we have in order to get the diagnosis? As always in medicine, we have history and physical examination. Then we have the skin and blood testing for specific IgE. We have in GI, we have endoscopy and biopsies. And then finally, we have elimination and challenge with a specific food, which we think the child is allergic to. So I have 2 slides on specific IgE, because often people completely overestimate the diagnostic tool of a specific IgE. And is a summary of a very nice report from Sicher from New York, which was published already 8 years ago, but it's really worth reading. And I think almost all of it is still valid 8 years later. So what do we have? We have blood tests, and some blood tests really screen for a whole group of different food allergens, what we call kind of screening panel. And then the child may be positive to 1 or 2 or 3, meaning sensitized to the different foods. But sensitizing does not mean allergy. So for instance, they looked in American children and they found 8% in American children are positive for a specific IgE against peanut, but only 1% have clinically allergic. So you have a lot of only sensitized without meaning disease. So never put sensitization equal to disease. So then you overdiagnose. But also the other way around, if you have a negative one, you cannot exclude allergy because of this specific IgE negative one. And also a negative test does not mean that you have only a mild reaction. You will see some of these children I presented, they are negative, but still have a very, very severe reaction, and one is in FPIES. So being negative does not mean that's a mild or harmless disease or not threatening. For food allergy, it is better to prick into fresh fruit than to use the extracts. And you always have to remember in those with very high IgE values that you often have a cross-reactivity between different proteins. So what does the wheal size or the concentration in the blood test tell us? The higher the concentration or the wheal size, the more likely it is that it is a meaningful sensitization, that this child really reacts, but it does not predict the severity. So you can have very severe reaction, even anaphylaxis, with only a small wheal size or low concentration. So again, this is often mixed up. Total IgE is not very helpful. IgG antibodies against different food have no meaning in diagnosing food allergy, so don't do that. It saves a lot of money and confusion. Also, intradermal tests are not recommended. And as I said, these FPIES and proctitis are often not associated with specific IgE test results. Now in clinical practice, and this is a very simple algorithm, which is also in the ESPGHAN guidelines, you take your history, you the physical, and then you have your suspicion. You have a suspicion of egg or wheat or milk allergy, and then you eliminate the food. You eliminate it completely, and you wait and to see whether the symptoms settle down. And you only have to eliminate a few days or 2 weeks, maybe in case of urticaria or atopic eczema until it settles down. In GI, you may wait a little longer, and then you have to decide, is there any improvement or is there no improvement? So if there is no improvement and the elimination was complete, then you can say it has nothing to do with the food, which I excluded. So you have to look for other diagnoses explaining the signs and symptoms of this child. However, if there is improvement, this is not a proof of the diagnosis, because this improvement can be by chance. So in order to prove really the causal relationship between the food and the reaction and whether this is really food allergy, you need a challenge. This can be done at home or open and double blind, depending on the specific situation. So this is a simple setup. Now we go into the details. Now we have our algorithm, and then we have our IgE testing. So when would you test when at this very top, when you have already a suspicion? And the suggestion is to test for specific IgE if your history and your physical examination has already a very high likelihood that you think, okay, I think very high likely that this child has a cow's milk or egg allergy. Then you should test here. And the situations are when you have an early, immediate reaction, a very clear connection between the ingestion and within minutes or 1-2 hours, an allergic reaction. So this very convincing history, then you should test. However, if you have a child with a very unspecific symptoms, let's say constipation or diarrhea since 6 weeks, or moderate eczema, not improving, or something with on a daily basis, so unspecific, then it is better to exclude first and only do the testing if there is improvement with the elimination. Otherwise, you would have to do a lot of blood tests based on this, based on the history. So it doesn't make sense to do the testing in all constipated or spitting infants. So then first look for improvement and then do the test. So this is depending on, very much depends on the history. Now let's solve our cases. So remember Paul? Paul was a little boy who vomited and had these breathing difficulties and was brought to the hospital with the immediate reaction and the urticaria in the face. So I assume that many of you said, yes, I think that he has milk allergy. But I want to put a word of warning, because this boy had milk and cereals. So of course, milk is very likely, but he could also have a acute wheat allergy or whatever was in these cereals. So I would not say yes. For my right answer would be very likely. He has a very acute, very typical history, and then the urticaria following difficulties breathing. So it sounds like an acute allergic reaction, but it could be milk or whatever is in the cereals. So he was tested for specific IgE. He was positive for milk, but negative for all other foods tested, including wheat and rye and so on. So, and then the next child was Carla. Carla, a similar history. You remember she started vomiting 2 hours after having also this milk cereal. She turned pale, lethargic, was brought to ICU by emergency, and had this severe metabolic acidosis. I don't know what you answered, but again, you can say the same with Paul. It could be also wheat, but it also could be something very different, because I have seen children with acute rotavirus gastroenteritis with diarrhea and vomiting and severe metabolic acidosis ending on ICU. So again, you have to, being here in a webinar on allergy, it still could be something completely different. And she was tested and she was negative for everything for specific IgE. So then let's go to our algorithm, and we start with Paul. So Paul, a convincing history of immediate type of reaction. Then he was tested positive, and this combination of a convincing history and specific IgE, in these cases you do not need to do a challenge. It would be even dangerous to do a challenge. So here you can make your diagnosis of cow's milk allergy. Put him on an elimination diet for at least 6 or 12 months, and then you would re-evaluate Paul. So this is a very easy IgE-mediated acute food allergy. Now, Carla, the similar history, but she was negative for the 2 tests. So in order to prove a causal relationship, whether this has anything to do with food or whether it's, as I said, for instance, rotavirus enteritis, you have to do a challenge test in her. And in fact, she was challenged and she had an immediate severe reaction again. And Carla is a typical case of what we call food protein-induced enteropathy syndrome, or FPIES. And the major criteria, as I said, are defined in this paper on FPIES in the guidelines. And they defined the criteria how to make the diagnosis, and you need this major criterion, which is vomiting within 1 to 4 hours after ingesting of the suspected food. And then in the absence of other classical IgE-mediated skin, like urticaria, like in PAUL, or respiratory symptoms like breathing difficulties, or in the absence of these, this is a major criterion for FPIES. And in addition to that, you need 3 minor criteria, and they are listed here. So either a history of already an episode in the past of this or to other food, and very typical is this lethargy and pallor. About 10 to 15% end up on ICU and need intravenous fluids because of severe metabolic acidosis or because of blood pressure problems. So they lose all the water into the gut. And then they develop diarrhea within a few hours after this acute vomiting. So this is a series of 160 children from Mount Sinai Hospital in New York, and they looked at the different foods in these children causing FPIES, and you can see milk is the most common one, but followed by soy, and then the third one is rice, then oats, barley, but you have also fish, you can have beef, even sweet potatoes, anything, green peas. So very harmless sounding foods can cause FPIES, not only the typical ones like milk and egg. And 2/3 of the children had reacted to one food, and 1/3 reacted to 2 foods. And when they were re-challenged, they reacted immediately. So the median age at diagnosis was already older, because often they can go sometimes 3-4 times to ICU because somebody said, oh, maybe it's FPIES. Often they think it's metabolic disease or something. Well, and then this acute reaction can go into a chronic one if it's due to a food which the child is on a daily basic ingestion. And most of the time, this is either milk or soy formula. I mean, in your countries and also in Europe, we don't use soy formula anymore, only very, very rarely. But in the States, soy formula is still more often used, and that's why they see more of these soy and milk related FPIES. So these children, they have more like a chronic diarrhea problem. They have low protein, they have failure to thrive, and a flat mucosa when you biopsy them. So they are really malnourished, sick children. And then they recover after, some of them need months before they recover, but if you challenge them, then they often react with this acute reaction. So this is not an easy diagnosis. You really should follow the criteria for the diagnosis. And if you have only a single acute episode, you need an orange challenge in order to prove a causal relationship. And this should be done really in hospital with an IV in, because they can collapse easily. If you have a case of chronic FPIES, young babies with failure to thrive and chronic diarrhea and flat mucosa, again, they should recover and they should be challenged later on, because without a positive challenge, you should not make the diagnosis. It's only an assumption. Some of these children, about 1/3, being a specific negative at the beginning, may turn positive later on. So we have discussed the
Dr. Sibel, could you just go a bit rapidly, because we are out of the time, if you don't mind.
No problem. I can speak also faster. So now we have to resolve Ali and Anna, and you remember the severe cases, and we thought maybe he has hyper IgE syndrome. No, He was a very, very allergic child with multiple food allergy, and we put in an amino acid formula. You see here the tube in, and his eczema resolved, and he started growing. So he was one of these children with very, very atopic child. And now Anna with a bloody stool. So often people think when there is bloody stool in a baby that is allergy, but most of the cases it's not allergy. It's a benign self-limiting condition, and only maybe 10 or 20% of these babies really have an allergic problem. So never switch a breastfed child to the bottle. And in a bottle fed, always wait for at least 2 or 3 weeks, and often it resolves by itself. And because there are many, many differential diagnoses, and in most cases we cannot resolve it. So as long as there are no alarm symptoms and the baby is thriving, just wait and see. And often it resolves when you start solid foods. Now the last child is the one with the thickened skin, and the refusal with solid food, and we scoped him, and he had the typical pictures of eosinophilic esophagitis, and that's why he was refusing. And you can see really the similarities between the skin here and the mucosa. So we tested him, and he was positive for IgE for milk, and we excluded milk, and it resolved both the EOE and also the skin and the anus. So the symptoms in EOE really depends on age, and the typical food impaction only appears in school-age children, and the younger the child, the more unspecific are the symptoms. And in 2/3 of the children, milk is a trigger, and 75% have only one food, and egg is a second, egg and wheat are the second ones. So here are the formula for babies, and here are the different manifestations, and you can see in most of them you need elimination and a challenge procedure. So which milk should we use in order to eliminate those where we suspect it and where we have proven allergy, and also for prevention? And we have the different formulas: amino acid, extensively hydrolyzed, partial hydrolyzed, soy, and goats. And which is not allowed in infants with a suspected or proven cow's milk allergy. So this is allowed, this is not allowed. No, this is allowed, the extensively is allowed, the partial is not allowed. Soy milk is allowed in older children, and goat's milk has a very high cross-reactivity to cow's milk, is not allowed. So you know, most likely this pictures the different degree of splitting here, amino acid, extensive hydrolyzed. So the whole proteins and the partial hydrolyzed should not be used. They are dangerous in those where you suspect or have proven cow's milk allergy. So only these two are what we call therapeutic formula, and they can be used. So what can we do in these babies? So we either use extensively hydrolyzed formula. If these babies already, or younger children, have most of it is solid food, then we can use soy. And in some circumstances, we need amino acids, but no other animal's milk, no camel milk or goat's milk, and no partial hydrolyzed. So extensively hydrolyzed is a first choice. Oops. No, something not showing up here. I don't know why. Disappearing. And also here I only have the headline. So these two slides, I don't know why they don't show up, but they tell you when you should amino acid first line. And these are in those with very, very severe manifestation, like Ali with failure to thrive, with this enteropathy, with protein losing and hypoproteinemia. So if you don't, if you really very severe diseases, then you should start with amino acids. But otherwise, in those with eczema or spitting, then extensively hydrolyzed formula is perfectly fine. So in breast milk, as I said, you can have allergy in fully breastfed. This is no evidence for colic, dysphagia, or GERD, but there is some with this proctitis and enterocolitis. So, but as said, it's very rarely. And most of the time, you don't need to switch to a formula, only in the very severe cases like in Ali. So if the mother, in milder cases, if the mother has only started the bottle, advised to go back to full breastfeeding, and then the mother should exclude milk from her own diet. If symptoms improve, then the mother should start drinking milk again or eating yogurt. And only if symptoms go back, the mother should come back, the mother should go back on this exclusion diet. But most of the time, the babies do not react to this very small amounts. Now, challenge, why do we need a challenge? And here are the data from challenges in children with GI manifestation with very unspecific symptoms. And they were negative for specific IgE, so these spitting, diarrhea, vomiting, constipation, and only a third of them relapse with a double-blind challenge. So you would overtreat if you would not do a challenge. When can you do that challenge at home? What we call kind of readduction at home. And this is always when you have not an acute reaction in the history, like constipation or chronic diarrhea. So these are not acute reactions. And also always the challenge can be done if through the mother's milk, because there is no anaphylaxis in breastfed babies where the mother is eating the food. So, and also if you have only a short elimination of a few weeks and no acute reaction, then you can tell the mother to start slowly at home. In all other situations, you should do it as an inpatient or under medical supervision. IgE testing will help you to distinguish or to tell you something about prognosis. So if you have a very high specific IgE, it takes longer to develop tolerance compared to those who are IgE negative. So IgE testing is not so helpful for the diagnosis in most cases, but for the prognosis. So the prognosis, the follow-up, it's not showing up for some reason. So my summary slide is not showing up. You also cannot see it, right? It's only, okay, so it's not coming. So I have to summarize out of my mind. So in summary, food allergy affects around 2–3% of the children. Symptoms are very, very unspecific. And because of that, and because we do not have a diagnostic marker, it is a very high risk of over and under diagnosis. So the best proof is to eliminate and challenge, and the specific IgE testing is helpful, particularly in those with an acute immediate reaction. In some cases, you may need endoscopy and histology. So again, a positive specific IgE, either in the blood or skin test, neither proves or excludes the diagnosis of food allergy. So never overestimate specific IgE testing. And this is done very, very often. So these strict diagnostic criteria, which we have outlined in our algorithm in the ESPGHAN guidelines, I think is very helpful. If you follow that, you will end up in the correct diagnosis and do not over and underestimate it. And this is, of course, very, very important for your children, but also to avoid unnecessary diets and costs for the parents. So I'm sorry that these slides didn't show up. So, but this is the last one, and I thank you for your attention.
Thank you, Sibel, for this wonderful and extensive communication that have led us to a very helpful knowledge on cow's milk protein allergy and on food allergy. many questions arise during the presentation. However, we can answer all of them. I will sum up those who were out of the scope. I mean, those who are a bit interesting for us. The question is, what would be the link of the food protein allergy with other food allergy, egg and the other? That means, is the one who develops cow's milk protein allergy early in life may also develop other food allergies later in life? A rapid answer, please.
Yeah, I mean, the most of the milk allergic children will not. So, I mean, if you have one, you should calm down and say your baby most likely will tolerate heated food, being a toddler. And as I said, when the baby has very high specific IgE, it may take longer. And then, but most of them have only milk allergy, and only a few have multiple food allergy, like Ali,
Yes.
the ones with very, very.
Okay.
But
this is yes. The second question, rapidly, is there any link between the immune response early in life and late onset disease of immunological diseases like celiac disease, diabetes, or something like that?
No, there is no relation between food allergy and celiac disease or diabetes. These are also immune-mediated diseases, but they are linked to certain HLA markers, which you do not find in food allergy. So they are different, what we call immune-mediated diseases, but having one is not increasing the risk for the others.
The third question, the soy milk formula. This is a little bit intriguing in our country. We don't have soy, so many of our doctors would say, let's put soya instead of amino acid free. This is maybe a bit hesitating for us. The second issue is soy formula harmful for the brain development or not?
Yeah, there is something in the soy why we do not like it to give it exclusively in the first half year to babies. And these are certain hormones, and these are certain other ingredients and this is a reason why the scientific societies recommend against using soy first line in babies. However, in the second half year, when you already eat bread and porridge and whatever, corn, so solids, and the proportion of milk is only maybe 20–30% of your energy intake, in these cases, yes, then you can give soy milk, because these older babies often do not accept the very bitter tasting extensively hydrolyzed formula. But don't give a 2 or 3 months old baby soy formula, which has cow's milk allergy, because about a quarter of them will then also develop soy allergy. So there are several reasons not to use soy in these early babies. But if parents cannot afford the expensive formula, then of course soy is better than continue with the milk or having a sick baby. So I think it depends on the setting.
Yeah. Could you comment a little bit on the Genie study, and have you any results for the 20 years back up?
Yeah.
And Sibyl, the other issue, could you comment on the oral tolerance that partially hydrolyzed formula can also produce?
The partially hydrolyzed was developed and really should be used for prevention. So because by definition, partial hydrolyzed is not sufficient if you're allergic, and about a third of cow's milk allergic children have severe reaction to this partial. So it's really for prevention. But for prevention, and the Genie study showed that and we could confirm that this 20-year follow-up really has a preventive potential in babies who are born into families where other family members, the parents or siblings, have allergies. So this was a setting where we studied the partial hydrolyzed formula. Yes, it's good for prevention, but not for treatment.
Okay, I have to recap a bit because we are a bit late on the schedule. Thank you very much, Sibyl, for this wonderful webinar. Let's sum up and say that cow's milk protein allergy, it's a clinical approach and a challenging approach. IgE specific markers are helpful in only acute mediated diseases. The other pictures could be triggering, but anyway, we have to keep in mind that food allergy early in life are due mainly to cow's milk protein allergy. The only treatment would be exclusively diet, exclusively on amino acid formula. Partially hydrolyzed formula are only indicated in the prevention of the cow's milk protein allergy, not in the treatment. Let's say also there is, please, I want to say that there is no room for soya in the first months of life in either the treatment or the prevention of cow's milk protein allergy. Thank you very much, Professor Sibyl Koletzko. Have a nice evening in Munich and convey our regards to all your family. And see you soon. I will now transfer the floor to my friend Dr. Saad, but before Dr. Tawfiq will introduce it. Thank you very much.
Well, I want to thank the Nestle Nutrition Institute and particularly Linda Habshi and Dr. Tawfiq for this invitation, and Professor Al-Saedi for his introduction. Professor Al-Saedi, your pronunciation in Spanish is very good. So you need to, if you teach me some Arabic, I will teach you some Spanish in the future. As Dr. Al-Saedi, Professor Al-Saedi said, indeed the topic is quite a new thing in the era of nutrition, because for years we always heard that protein deficiency was the problem, and giving more protein was the goal for every growing baby. During the course of this talk, I would like to present to you newer information that says that extremely high protein not only is not beneficial for the growing baby, but also could be deleterious. We heard Professor Koletzko, and I'm going to be talking a lot about the work of Dr. Bertolt Koletzko, Professor Bertolt Koletzko, who actually has been a pioneer in the topic that we are discussing today. And it's the impact of early nutrition on long-term health and what is called the power of programming. As you know, in life, there are periods of sensitivity that have developmental plasticity, where nutritional and metabolic factors have a special role and a very relevant one, which will be forever lasting. During the baby has a prenatal exposure of maternal issues such as maternal obesity, diabetes, and stress. And postnatally, there are things that can be done immediately after the birth, which is to encourage breastfeeding and then to choose complementary feedings appropriately. We know that these will affect hormones, metabolome, the microbiome, the epigenome, and growth. There are hormones that will be produced by the mother that will affect the baby, not only in utero, but will have a after effect. And all these issues will have in the offspring a result on potential creating adiposity and obesity with abnormal growth and fat deposition, insulin resistance, and disease such as diabetes and stroke. If you have been to London, you know that the British have very funny names for the streets. And when I was walking, I saw this street, Milk Street, which I thought it was an appropriate slide to bring today, particularly for those people who like to travel. These last few months have been like a prison. So I thought that I would bring this slide today. What are the unique features of breast milk supporting the infant's development and developing the digestive and immune system? Well, of course, we know that breast milk is the main building block for growth and development. It regulates the immune system, it programs metabolic system, and is less stressful on the digestive system. Breastfeeding decreases the risk of type 2 diabetes, has a positive effect of cognitive development, decreases the risk of overfeeding the baby, decreases the risk of overweight and obesity, not only in the baby, but also in childhood and later in life. It diminishes the risk of allergic diseases and the severity of lower respiratory infections and gastrointestinal infections, in addition to a decreased overall morbidity and mortality due to infectious diseases. So the WHO, which has been a lot of controversy in the last few months because of the COVID pandemic, but published this information in 2013, which is breastfeeding is an unequal way of providing ideal food for the healthy growth of development of infants. Now, there are very major differences between cow's milk and breast milk. And I've mentioned cow's milk for those babies who are unfortunate enough that cannot be breastfed. So essentially, one of the differences that we're going to be discussing today is the protein quantity and quality. Breast milk has a predominance of whey protein, while cow's milk is exactly the reverse. Casein is the most abundant. Whey protein is water soluble and hardly forms any curds. It's more quickly emptied from the stomach of the baby rather as opposed to casein, and is more quickly broken down into absorbable small peptides and amino acids. So of course, from the digestibility standpoint, gastric emptying standpoint, breast milk is much better than cow's milk. Breast milk contains partially broken down proteins as well. There is an extensive peptidomic analysis of breast milk have shown that there are more than 300 milk peptides present in breast milk, and the digested peptides represent only a minority of the total protein content, but it's very important because it makes breast milk act like a partially hydrolyzed protein content. These enzymes sort of start digesting the milk proteins before they actually the milk gets to the baby's stomach. Continuing process of digestion will occur in the stomach and then in the small intestine. This is to say then that intact cow's milk formula will not have any broken down peptides, and everything will have to start, the digestion will have to start once that the formula reaches the baby's stomach. Continuing process of digestion will occur in the stomach and then in the small intestine. This is to say then that intact cow's milk formula will not have any broken down peptides, and everything will have to start, the digestion will have to start once that the formula reaches the baby's stomach. As Professor Coleczo mentioned before, there are also main differences in regards to the allergenicity of the cow's milk protein versus breast milk, because breast milk proteins are not identified as antigens by the infant's gut-associated lymphocyte tissue, and therefore they do not elicit an immune response. If a breastfed baby will develop cow's milk protein allergy, is from the cow's milk protein that the mother ingests in her diet, but not from her own protein production. So there are, as you know, there are different concentrations of protein in the different species. Human milk contains 1.6 grams of protein per 100 grams of milk, while cow's milk is more than twice than that. Rabbit is almost 5 times that of cow's milk. Dog is also very high, and camel milk, although it is not recommended, it is very similar to that of cow's milk. As I mentioned today, just recently, or just a minute ago, this is the difference between cow's milk and rabbit milk protein content. The rabbit grows very fast, and this is one of the big differences in growth and accumulates fat very quickly. It is interesting that I found in searching a few case reports of babies whose parents fed their infants with rabbit milk, and this is what happened. There are also other differences between human and cow milk in regards to protein, and predominantly the fact that human milk has no beta-lactoglobulin, which is the most allergenic fraction of proteins. And also the amount or the concentration of protein in breast milk is not constant. And as you can see in this graph, over days of life in the x-axis versus protein content in the y-axis, you can see that very rapidly the concentration of protein in breast milk falls to then from a nadir here to some kind of plateau about 1 month of life. This, of course, does not happen with cow's milk. Well, the world has been changing and moving from this to this. And with that, we need to see what us as pediatricians can do and how the different ways in which we can prevent or at least reduce the risk for obesity or overweight. Obesity accounts for almost 7% of total healthcare costs globally. And according to WHO, the annual rate of increase in the prevalence of childhood obesity was 10 times that of the 1970s in 2013, and that is already 7 years ago. There is now data that with the COVID quarantine, obesity is even higher, the rates of increase are even higher than what it was. But specifically, the global prevalence of overweight and obesity in children rose from a 4.2% in the 90s to 6.7% in 2010, and that is again 10 years ago. There are many studies that have looked at the effect of the protective effect against obesity of breastfeeding, and this is a forest plot indicating the benefits of breastfed infants in preventing or reducing the risk of obesity. This is the line of no effect, and we can see that every single mean of these studies shows that the breast milk favors prevention or decreased risk of obesity compared to formula-fed infants. And the effect is about 22% benefit and reducing the risk. Why is this? I mean, why can cow's milk formula or cow's milk derived formula cause obesity? And it could be that it's a high glycemic index with an unbalanced nutrient content of the milk available on the market for non-breastfed babies. In addition to glucose, certain amino acids are capable of increasing the insulin secretion, such as arginine, lysine, leucine, phenylalanine, valine, isoleucine, and threonine. This means that compared to breast milk in pink, these amino acids have a 50% greater capacity of increasing the insulin response compared to breast milk. breast milk contains low amounts of insulogenic amino acids, which are insulin secretagogues. Breastfeeding thereby reduces the tendency towards early weight gain and adipogenic activity. So it would be interesting to say that perhaps by lowering the amount of these amino acids, i.e. lowering the concentration of protein in infant formula, one could have a beneficial effect on adiposity and rapid weight gain. If we compare the growth of breastfed infants and formula-fed infants from 0 to 18 months, this was the Darling study already from many years ago, we can see that when we look at the mean weight of breast and formula-fed females adjusted for birth weight, we can see that from very early on, formula-fed girls have a higher weight for age than the breastfed babies. When we look at the weight for length scores, Z-scores, we can see that very early, already by 5 months of age, the weight for length Z-score is significantly higher if the baby was formula fed versus the baby being breastfed. So this is where the window of opportunity for programming takes place. And that is the moment for us to be able to intervene if the baby is not being breastfed. Rapid weight gain in the first half year of life, a greater than 90 percentile, is associated with a greater risk of obesity at 6 to 8 years of age. This was already noticed in 1970. Multi-center cohort study in the United States indicates that rapid weight gain during the first 4 months of life, that is more than 100 grams per month, that is acceptable, is associated with overweight at 7 years and at 20 years. So what is the problem if the baby ingests more protein than what they need? The body uses the amino acids needed, but the excess of amino acids that are present in infant formula when routine infant formula remain in the bloodstream, and therefore they have to be converted to urea to be excreted. And that results in an extra work for the immature kidneys. But in addition to that, poor protein quality, but also high protein quantity increases, as I mentioned before, the amount of insulogenic amino acids, leading to an increase in insulin, increase of insulin growth factor 1, with early weight gain, and then increased adipogenic activity, which will be having an impact for the rest of this baby's life. The protein requirements range from 1.12 grams per kilogram per day at age 6 months to much, much lower at 10 years of age, about 0.74. And the corresponding values for the safe level are 1.43 grams per kilogram per day at 6 months and 0.91. So one should definitely not exceed those levels. Now, of course, I think that I've told you now that there is a risk that higher protein content in infant formula might elicit an adipogenic activity, and early growth or excessive growth or weight gain in babies might lead then to future obesity. So what is the evidence that lowering the protein content in non-breastfed infants, we might reduce rapid weight gain and decrease risk of obesity? And again, here we present a study and a series of studies done by Professor Bert Koletzko, which have been a paramount contribution to understanding this concept. This study that was published already several years ago indicated that lower protein in infant formulas was associated to lower weight gain up to age 2 in a randomized placebo-controlled double-blind study. Professor Koletzko created the Early Nutrition Programming Project, and this is part of his studies. So the Professor Koletzko and his multinational team in Europe they randomly assigned in a double-blind manner infants whose parents had decided not to breastfeed their babies to either a lower protein containing formula or a higher. And make sure that you follow me in this. It's not low protein, but lower protein. And this is higher protein. So the protein was sufficient to secure full-term baby's growth, but not at the levels that routine infant formula had at that time. More than 560 babies were assigned to each group, and they're followed progressively for several months and then for several years. As you can see here, describes the two formulas that were used, and here is the main difference between them. In grams per 100 milliliters, the lower protein formula contained 1.25 versus the higher protein 2.05. As pediatricians, I would like to call your attention that when you look in the packages of infant formula or in the leaflets, to make sure that you are comparing apples with apples and not apples with oranges. Because if you look at protein in grams per 100 kilocalories, and you look them like this, they might not be that different, but you have to compare grams per 100 mLs or grams per 100 kilocalories. And infant formulas usually are expressed in both, so pay attention to that. So what are the results of Professor Koletzko and collaborators' studies? Well, essentially you can see that by 6 months of age, the babies who were receiving the higher protein formula had a significantly greater BMI Z-score than those who were receiving a lower protein or the breastfed babies controls. And this difference continued at 12 months and 24 months. So we could say, well, why not use, what's such a big fuss? Let's company formulas reduce the amount of protein in the product, save some money, and we be resolved. Well, the situation is much more complicated because there are some amino acids that are very limiting and they're already low. So if you just decrease the amount of protein in the formula without supplementing essential amino acids, you might run into deficiencies. So you can see here that, for example, what needs to be done is to selectively increase the amount of tryptophan and decrease the amount of threonine. Otherwise, you would have deficiencies that would not allow for normal growth. These amino acids, for example, the tryptophan, is already quite low in breast milk. So it's a borderline concentration for needs that you cannot reduce even further. So what you do is you reduce the amount of protein in the infant formula, but you supplement it with fractions that are threonine rich, so from whey, so that you can result in this level of appropriateness. And essentially what has been seen that using the lower protein formula, and this is a meta-analysis of high quality randomized controlled studies that were done subsequently, all show appropriate weight, length, head circumference, and BMI, similar to those that are seen in breastfed infants. The lower protein formula provides healthier outcomes on the digestive and excretory systems. They are significantly lower plasma urea concentrations when compared to the higher protein formula. And also these are decreased problems with constipation, colic, and diarrhea compared to standard formula. And here you have the breast milk control, and this is your lower protein, and this is the higher protein. Now, when you look at, we're very fortunate to be able to continue seeing not all of the 500 babies that were enrolled in the study in each brand, in each part of the study, so a total of 1,100 babies were initially enrolled. Not all of them could be followed up, some were lost to follow-up, but what they were able to see at 6 months of age, a very important thing, which is the body composition at 6 months of age, the total fat mass was in the lower protein significantly lower than in the higher protein. And similar, the lower protein similar to that of the breastfed. And as I mentioned before, the higher protein content in the formula results in an excess of protein, resulting in an excess of urea, and meaning that they require extra volume, extra work, for the kidney, for the immature kidney. So in this follow-up study, what they saw is that the babies, boys and girls, who received the lower protein formula content, protein, the kidney volumes were significantly lower than the kidney volumes of babies who had been assigned to the formula with higher protein, indicating, you can see here, higher protein kidney volumes, and particularly for boys. At 2 years of age, so again, these are the babies who were able to be followed until 2 years of age, you can see that lower protein resulted in a weight for length that was lower than the higher protein. So the impact goes well beyond, because this formula was only given for the first few months of life, and the impact on weight gain continues well beyond the time of formula feeding. Here we see a follow-up at 5 years of age of the same group, where there was an association of early protein intake and pre-peritoneal fat at 5 years of age. And pre-peritoneal fat, measured by ultrasound, was higher in the children who, as babies, had received the higher protein formula compared to those who had been assigned to the lower protein formula. So higher protein intake in formula-fed infants appears to enhance pre-peritoneal fat accumulation in the preschool age, but not of subcutaneous fat tissue. This observation supports the hypothesis of programming effect of early nutrition on mechanisms responsible for fat distribution. And when we look at school age, this is the lower protein content in infant formula reduces the BMI and obesity risk at school age. Again, this is a study that followed these babies until 6. And when you look at BMI at the different ages followed here, and this is 6 years of age, we can see that particularly children who had the highest BMIs were particularly at risk of a very significantly higher BMI at age 6 if they had been fed the higher protein formula. This effect was not so evident in the children whose BMI was not that high. So essentially, if the child has a risk, a familiar tendency to have a higher BMI, will be the most benefited by the lower protein formula. And this effect, as you can see here, is quite dramatic. The differences at 6 years of age between children fed higher and lower protein infant formula is a BMI of more than 0.51 for those who receive the higher protein, and an increased risk of obesity times 2.43 compared to the lower protein group. And these differences, of course, are significantly different. So the increased protein intake in infancy resulted in a greater weight gain of around 2 grams per kilogram per day. So if you extend this over time, you can realize what we have been talking about increased risk. The impact of the lower protein was not only seen in body fat, but also in the type of microbiota seen in the fecal, in the feces of these babies, where the babies who received the lower protein formula had a similar count of bifidobacteria than those who had been breastfed, as opposed to those who had received the higher protein content formula. Now, what evidence do we have that this is healthy, that the babies grow appropriately with a lower protein formula? And this is a systematic review and meta-analysis of risk factors for child overweight identifiable during infancy, indicating that indeed early rapid weight gain, high birth weight, maternal pre-pregnancy overweight, and maternal smoking in pregnancy increases the likelihood of childhood obesity and overweight. When we looked at the growth of the babies who received the lower protein formula, we can see that is comparable to the breastfed babies. So the growth patterns of the lower protein are comparable more to the breastfed infants than those than the higher protein formula. And finally, there's a systematic review of controlled trials of lower protein or energy-containing infant formulas for use by healthy full-term infants. And we can see here that the study suggests that adequate growth during infancy and early childhood with infant formulas with concentration of protein and energy slightly below those historical standards in the United States are beneficial and lead to the benefits that I have discussed. Shukran.
Thank you very much, Dr. Carlos, for very interesting talk about also a very interesting subject. Now we'll come to the questions. Maybe we have a lot of questions actually, but maybe we'll choose some of them, Dr. Carlos.
Yeah, let's see, where are my questions here?
Okay, the question is, maybe I'll say the first question. How specific and sensitive the IgE level in the diagnosis of allergy? This is maybe from the previous talk. Let me, okay.
There is some question on the HMO in breast milk. I have seen that.
Yes.
The guys asked if there is HMO content in the milk in the cow's milk, and what is the interest of HMO in association with the protein?
Well, that's a very interesting question. The amounts of HMOs, that is human milk oligosaccharides, present in cow's milk are negligible. So if although human milk oligosaccharides have been known to occur for over 50 years, only more recently have people started to pay attention to that. And it's only the addition of HMOs to infant formula which will help. There is no association. The HMOs are determined by genetic component and group, by the expression of genes and the blood group of the mother. There are also some geographical differences, but they are not related to protein content. But again, it's a very important topic because it's another contributor to making human milk, infant formula closer in some aspects to the value of breast milk. Of course, never replacing it, but trying to obtain some of the benefits.
There is another question about the role of alpha-lactoalbumin in low protein infant formula to have the same amino acid profile of the breast milk.
Well, I don't want to say, I mean, I don't like the term low protein because it always, among doctors, it brings up the scare. Well, a low protein formula. And again, I want to emphasize that we're talking, the studies were done in full-term healthy babies. This does not apply to the premature infant. This does not apply to the small for gestational age infant for whom there are very few studies really looking and what's best for them. But the alpha-lactalbumin is present in both cow's milk and infant formula and cow's milk, in breast milk and cow's milk. And what it is done in order to tailor the cow's milk formula is part of the whey is separated. It is enhanced, some of the amino acids, and then they are mixed again in the product. So essentially the beta-lactoglobulin is the allergenic one. Alpha-lactoglobulin is present in both cow's milk and breast milk.
There is another interesting question which says, when the maximum effect of the protein programming occur early in life? Any specific age?
Well, the studies have been done in very young babies who receive the formula for 6 months. At a certain point that the formula was changed to another protein content, but essentially the study included babies who, as I mentioned before, the parents had decided not to breastfeed, and when immediately enrolled, then and randomly assigned. So, you know, it takes a few days. I'm not sure that the babies might have been perhaps 15, 20 days at the time of enrollment. How long that programming period exists, I don't know. But I can tell you that I came across another study which was done in adult volunteers who were overfed. They came into the metabolic unit and they were overfed. Some of them received high protein and high calories, and others received normal protein and high calories, and another group received lower protein and high calories. And the group, and again, these are healthy volunteers, adults, the group that received the lower protein and high calories gained less weight than the ones that receive exactly the same amount of calories, but with high protein. So it seems that protein might play a role in weight gain with excessive calories, even in adult life.
Okay, there is another question about could high level of protein in the formula causes any health hazard other than obesity?
Well, they are linked because the risk of obesity is increased. It will increase the risk for type 2 diabetes. It will increase the risk for other problems that might be related to obesity. There are no, as of today that I am aware, there are no health issues such as immune competence diseases or so on. But again, many of these things are still in the works, and as more and more babies now are being fed lower protein formula, is going to be, investigators will be able to determine if there are differences in situations other than the ones that you, Professor Al-Saidi, just mentioned.
Great. There is a lot really of interesting questions. This question saying, is there a difference on the level of growth outcome and brain work in lower protein formula or hypoallergenic formula, which is better? Of course, in your presentation, Dr. Carlos, you answer part of this question regarding but what about brain work? Is there any difference between lower protein formula or hypoallergenic formula, and which is better?
Thank you very much. That is an important question. I am not aware that that has been studied or published as of yet, but there are differences then in development and behavior and learning with the addition of HMOs. And those studies now are coming out. There's recent publications. There were early animal studies in rats being fed HMO or no HMO with greater learning capacity of the animals that received the HMOs. And now there are early studies showing in infants, again, an enhancement of certain learning development with HMOs. I'm not aware that anybody has reported anything regarding the protein level in their diets.
Okay, thank you, Dr. Carlos. There is a question here. I think a lot of people, they ask it from time to time, maybe not directly related to the presentation itself, but maybe you answer us if you have an answer. About comparing children on breastfeeding with the children who were fed artificial feeding regarding IQ.
Yeah, this is a very interesting question. And, you know, the problem, there is no doubt that breastfed infants in many aspects perform better in certain aspects. Particularly, this was noticed before the addition of docosahexaenoic acid into formulas. Docosahexaenoic acid is it's a non-essential long-chain polyunsaturated fatty acid, but it was seen to have a great impact on brain development and particularly in visual acuity. Now, the breastfed baby is not only receiving breast milk, but it's also put to the breast. And the psychological impact of nurturing the baby to the breast cannot be compared to that of giving infant formula. So there are a lot of issues that come along with breastfeeding. It has to do with social, with cultural, the possibilities of wanting to do it, not having to go back to work. So it's very difficult to tease out all these variables regarding the product itself, because breast milk is not just breast milk, it's breastfeeding.
Yes, a lot of factors other than the nutrition value. Yes, you're right, Dr. Carlos.
Dr. Saad, Dr. Saad, can I just intervene on the low protein or mean? I would suggest that it is the normal protein formula, not the low protein formula, in order to be on a safe side. On the optimal growth, and Carlos has shown a very nice slide on the effect of those protein formula on height, weight, but also on head circumference. So that means that it has an optimal growth on head circumference. That means all that those lower protein or normal protein does not affect the growth of the brain. And if the head circumference is maintained as it is, that means that those have indeed engaged a normal head growth. And that means that those lower protein formula or normal protein formula, let's say, are healthy for the development of the infant.
And Dr. Carlos has mentioned that they have a comparable outcome, those who receive the breast milk.
I just meant the question on brain development, that the head circumference was similar. So that means that the protein that does not affect negatively the brain growth too.
Yes. Now, this is also a very interesting question. Is variability of protein concentration in the mother milk and the quality of protein documented? The mother, the amount, the quality of the protein in mother's milk. So what are the factors which are affecting it? We know generally that whey protein, 30 to 40%, 70 to 80%, and 20 to 30% is casein in the breast milk. Is this affected by the maternal diet?
Well, thank you very much for that question. As I showed you, the protein concentration drops in the first few weeks of life to a plateau, after which it continues to drop. Of course, the protein concentration in colostrum is much higher than that in breast milk, but even in the first 10 days of life, the protein concentration in breast milk as a norm drops. There are differences related to nutrition on, for example, docosahexaenoic acid concentration in breast milk, where in mothers who live or who eat fish as part of their diet will have much higher DHA concentrations than those who do not consume particularly oily fishes such as salmon or mackerel. There are many studies that have done, for example, comparing mainline China, rural China versus marine China, where of course in the marine China, the mothers do ingest fish and the concentrations of DHA almost double. That is not so for protein concentration, and the nutritional status of the mother has to be very, very much impaired in order for the protein content to go down. Studies of mothers who are very poorly nourished indicate that the volume decreases and that it may reduce the quantity, because what nutritional status seems to affect the most is lactose production. Lactose, the carbohydrate, attracts water to the mammary gland, and when lactose is low, then there will be less water being attracted, and then the volume is decreased. Of course, mothers that are deficient in vitamin D as well will have the problem, and the mothers who are deficient in iron and iodine. So there are many of the micronutrients that seem to be affected and related to maternal nutrition, but not so much protein concentration.
Dr. Carlos, there's a question here. How soon do we see improvement in the babies or children BMI after switching to lower protein formula? Has any studies addressed that?
Well, again, as you can see from the studies involve about 300 babies. On an individual child, the differences might not be noticeable. And I don't think that there are any studies where babies were started on higher protein and then at some point decreased to lower protein. That would be a very interesting study also to answer the other question, which is how long does the window of opportunity of intervention last? Because if somebody were to do that study and say, for 4 months you feed higher protein and then you decrease, is there still time to change the route to higher BMI and the risk of obesity, or is that too late? I don't have the answer. I don't know that if anybody has the answer. The ideal thing is to start the child who is not going to be breastfed on a formula that contains a lower protein content and not switch afterwards.
Is there any confounder in the BMI in children? For example, does maternal smoking associated with higher BMI in infant? Does these studies which address BMI address the mother smoking if it's confounder? Well,
you can always say, oh, I know a mother who, mothers who smokes a considerable amount will have placental insufficiency. So the babies might be smaller. And then if they gain weight and if they're not breastfed and they're fed a formula with high protein, they will be at greater risk. While if that same baby, if the mother were to breastfeed, perhaps it would decrease the risk. So there are many variables. There are some variables that they add each other. So if you have a mother who's overweight, who smokes, does not breastfeed, then the chances are that that baby will be having a greater risk of obesity, as opposed to that mother who was able to breastfeed or wanted to breastfeed even if she smoked during pregnancy.
What about the breast milk for premature infant versus formula in this population, preterm infants?
I will let Professor
regarding
Al-Sayedi respond that. I
We
have
have,
always,
we are out of time. We have to run a bit quickly.
Okay, maybe
Okay.
we'll answer this question and we wrap up. Thank you. Yes, Dr. Carlos.
No, I'm not a neonatologist. And when neonatologists call me in consultation, I always fear because they know all the answers. So I would say that perhaps you, Professor Al-Sayedi, being head of a neo-ICU, could answer that question better than me.
Regarding this, definitely the mother's own milk or breast milk is associated with less incidence of necrotizing enterocolitis. At one point, if we have breast milk when the baby on full feed, or in some unit when they consumes about 100 mils per kilo, they added human milk fortifier. Definitely, if you have breast milk, it's superior regarding necrotizing enterocolitis. Well, I know there is a lot of questions, but I think the time is running. At the end, I would like to thank you, Dr. Carlos, for this really excellent presentation. And I would like thanks to the audience for this, for the attendance through the net, as well as your important questions and interaction. And before that, also, I would like to thank NISLA for really this important scientific events. And I hope this effort will be continued. Thank you very much.
Dr. Mikdady, for these very nice introduction words. And I can tell you that at this moment it's 20 degrees in Brussels and it's sunny. Yesterday it was 30 degrees, wintry and very rainy and cloudy. So certainly happy when it's possible to come to the sunny Middle East again. As you mentioned, I got the almost impossible task to discuss with you the medical management of functional gastrointestinal disorders and prevention of allergy and management of allergy to see if it's related or not. And it's quite a challenging task. And I must say, I still do not have the answer to that question myself. This is the layout of my presentation. So it's a mixture between allergy and functional gastrointestinal disorders. And let's start with the introduction, which is of course starting by saying that it's beyond any doubt that breastfeeding is the best way to feed all infants and that every effort should be made to stimulate breastfeeding as much as possible. And if there would be more breastfeeding, we should have less allergies and probably less functional gastrointestinal disorders. Together with Rosanne Meyer and a group of co-authors from the European Academy of Allergology and Clinical Immunology, we published last year a first paper on diagnosis and management of non-IgE gastrointestinal allergies in breastfed infants. And you see the symptoms here divided in how long after ingestion of the allergen they appear. It's short term, less than 1 day, 1 to 3 days, more than 3 days. And this is for breastfed infants, but the same symptoms are of course true for formula-fed infants. And we are now in the finalizing another paper on just functional gastrointestinal disorders allergy in formula-fed infants. What did we see for the rest say in this paper is that most common symptoms of non-IgE mediated cosmic protein allergy are gastroesophageal reflux, reflux disease, infantile colic, and stool composition changes, as well diarrhea as constipation. And you will agree with me that for functional gastrointestinal disorders, these symptoms are exactly the same. So if these symptoms are in combination with atopic dermatitis, with respiratory symptoms, or with more seldom symptoms as FPIES, food protein-induced enterocolitis, then the likelihood for allergy becomes, of course, more prevalent. But on the other side, we must also accept that 20–25% of all the infants have atopic dermatitis. So the combination can just also be by coincidence and not related to a same cause. So combination of skin and gastrointestinal symptoms increases the likelihood for allergy, but a combination by coincidence is certainly possible given the high incidence of all these conditions. What certainly makes allergy less probable is that if you have one of those symptoms, reflux, constipation, crying or colic as a single manifestation. So it's a combination of these symptoms which maybe will make the allergy as diagnosis more probable. Although I will show you later that for functional gastrointestinal disorders, most of the infants also present with a combination of these manifestations. So based on symptoms, it's not always very easy to decide if that child is allergic or has a functional disorder. And what is a functional disorder? Well, it's if after appropriate medical evaluation, the symptoms cannot be attributed to organic disease. But organic disease itself, of course, does not preserve the infant to not have a functional gastrointestinal disorder. There again, there can be a combination just by coincidence, and having an organic disease does not preserve you, protect you to develop a functional disorder. So given the high incidence of all those conditions, there is absolutely overlap. So a few words about the incidence and the prognosis. How frequent is cosmic protein allergy? Well, according to the literature, in breastfed infants, it's very rare. It's less than 0.5%. But in formula-fed infants, it's 2 to 7%, and most of the literature says 3 to 4%. But there is a huge discrepancy between perception and proven allergy by double-blind placebo-controlled food challenge, and perception incidence is much higher. What about the incidence of functional gastrointestinal disorders? These are is from a paper looking at the literature, and you see that the median value for infants presenting with troublesome regurgitation is about 25%, 1 in 4. For colic, it's also about 20%. And for constipation, it's about 10 to 15%. So these conditions, these functional gastrointestinal disorders, are very frequent. But as I said about allergy, it's rare to have only one symptom. We must be aware also that having colic predisposes the infant to a higher incidence of other functional gastrointestinal disorders. So that's shown in this slide, dark gray colic, light gray no colic, and you see that all the other functional gastrointestinal disorders are much more frequent in the infants who do have colic. So colic predisposes to have a combination with other functional gastrointestinal disorder. And these recent data from France are even more convincing about that combination. Right. So it shows you that in those almost 3,000 infants, that 77%, so 75%, 3 in 4 present with a combination of 2 functional gastrointestinal disorders, and 15% with a combination of 3 functional gastrointestinal disorders. So combination of symptoms does not indicate allergy per se, because majority of the infants with a functional disorder also present with a combination of symptoms. And this is from an older study from Italy, and the incidence here is slightly lower, but you see that already 20 years ago in a study of 600 infants, 200 with colic, 200 with regurgitation, 300 with constipation, that the percentage with more than one functional gastrointestinal disorder was not 75, but 25%. It's still a high incidence of combination of symptoms. What about the natural evolution? Well, it's said, according to literature, that the majority of infants become tolerant to cow's milk protein at the age of 3 years, although I'm convinced that for the majority of infants, this is much earlier. And I think that about 70 to 80 to 90% even is tolerating cow's milk protein at the age of 1 year. IgE does not help for the diagnosis of cow's milk protein allergy, but may help you in prediction of tolerance. The higher the IgE, the later the tolerance will develop. And if IgE is really high, then some infants may not become tolerant to cow's milk protein. But so the vast majority of children with cow's milk protein allergy become tolerant to cow's milk protein at around the age of 1 year. But functional gastrointestinal disorders also disappear at more or less younger age or similar age. This is the natural evolution of regurgitation. And you see that it decreases very much at the age of 6, 7, 8 months and stays lower than in younger infants. And we all know from clinical practice that around the age of 1 year, when children start to walk around, that regurgitation decreases significantly. Colic disappears at about the age of 3, 4 months, and incidence is 20 to 25% of all the infants as shown on this slide. So for that reason, we tried to develop a score, the COMI score, the cow's milk related symptom score. It's a combination of crying, regurgitation, stool characteristics, skin symptoms, and respiratory symptoms to give a score which then may give you the likelihood that the child may be allergic because of the combination of symptoms. And percentile 95, which would then be the cutoff between healthy and maybe allergic children, is at a score of 9. The score goes from 0 to 33. So that may be helpful for healthcare practitioners to suspect cow's milk protein allergy, not to diagnose it. Is it important to diagnose functional gastrointestinal disorders and to treat them? Because you could say they disappear anyway. Yes, it's important because there are long-term consequences related to functional disorders. Children who develop colic, for instance, still have behavioral disorders when they are at the age of 4 years. So there is a long-term consequence on quality of life if you have a functional gastrointestinal disorder. So it's just as allergy at early life predisposes to become more allergic to other allergens later in life, the same is true for a functional disorder. It makes you susceptible for functional disorders later in life. So how should we manage those functional gastrointestinal disorders? Let's first look at regurgitation. Well, for regurgitation, there is consensus that if the infant is formula fed, that the thickened formula, anti-regurgitation formula, is recommended because it reduces the frequency of regurgitation. So that's from the previous slide, was from the NASPGHAN North American or European ESPGHAN guidelines. But the NICE guidelines, which are the guidelines for the United Kingdom, just recommend the same, offer a trial of thickened formula. And if that stepped care approach is unsuccessful, then you could go to the alginate therapy. But so thickened formula is what is recommended in the United Kingdom. And a Cochrane review from 3 years ago came exactly to the same conclusion, said that feed thickeners can be useful in term formula fed infants with troublesome gastroesophageal reflux. So the question you could ask then yourself is, offer a trial of thickened formula, should you give that for a long time or not? And I just put in that question to make you aware of the importance of this question. And in fact, not much literature has looked at this, but these are data from France showing you that at inclusion, 80% of the infants, or no, that infants did regurgitate 80% of their feedings. And after 3 days with thickened formula, that was reduced by 50%. It went from 80 to 40%. And you see that after 2 weeks or after 1 month, it's still 40%. So no further improvement. And these data from the Philippines will not go in detail, but shows you the improvement within 1 day. So improvement with thickened formula goes very fast, which means that if you prescribe a thickened formula for a vomiting, regurgitating, crying infant,
that told us several years ago that the triple-negative breast cancers they have
you should do it for 1 week and you see the improvement. This is also true for this study, which comes from Italy, showed that the improvement with this thickened formula, with partially hydrolyzed proteins, etc., but that you see that the improvement was within the first week. So in a functional gastrointestinal disorder, the improvement goes very fast. And again, it's important to manage regurgitation because infants with spilling up during the first 2 months of life, they are much more higher risk, they have a much more higher risk to have reflux symptoms at the age of 9 years. So what should the management be? Regurgitation, avoid overfeeding, thicken the feeds, and continue breastfeeding for the breastfed infant. And if that does not help, you could consider then an extensive hydrolysate because it could be allergy. And if that does not help, you could consider alginates. What about colic? Well, what is colic? Well, colic is, we are away from the 3 hours, 3 days, 3 weeks for the definition. It's unconsolable crying, it's irritability, fussing, reported by the parents, and it cannot be resolved by the caregivers. Again, a question, infantile colic occurs male infant for 4 months and has no long-term consequences. Is that true or false? Because we always say it's benign, it goes over, it disappears at the age of 3 months. But first of all, let's look at the knowledge and attitudes of pediatricians in your region. Which say that almost 100% diagnose colic predominantly by clinical examination, and the colic prevalence rate estimated is here even more than 40% in your region. And again, having colic predisposes the child to have abdominal pain later in life. And the opposite is also true. This study looks at children with chronic abdominal pain at the age of 8 years. And you see that if you have chronic abdominal pain at the age of 8 years, you have a 2 to 3 times higher risk to have other functional gastrointestinal disorders as an infant, and a 3 times higher risk to have had colic. Long-term consequences, I will rapidly go over it, but colic and behavioral outcome and mental health in children with colic up to the age of less than 5 years. Some studies say there is no difference, but other studies say there is increased internalizing and externalizing problems, more aggression, more sleep problems, socially withdrawn, anxiousness, depressed, temper tantrums, less enjoyment of meals in older children, association with hyperactivity and attention deficit disorders. Colic and physical health. There are papers which relate colic with increased incidence of atopic disease, with allergic disorders, recurrent abdominal pain, functional gastrointestinal disorders, ear infections, migraine. Colic and cognition. Studies which say that an infant with colic have later in life lower perceptual scores, a lower total IQ. Colic and family functions. Decreased subjective family function is reported. So this study from 20 years ago, follow-up at 4 years for infants with colic, shows that infants who had colic at the age of 4 years still have emotional problems they less frequently enjoy, means they have a selective food refusal. And it's also related to maternal depression. An infant with colic depresses the mother. And if you decrease the colic, then the maternal depression scores decreases. So colic does have a long-term functional impact. And it's very well known from literature that infantile colic is related to risk of allergic gastrointestinal and behavioral disease. So how to manage colic, behavior with medication, with probiotics, with dietary treatment, or prevent it? There are the 5 S's, the calming reflexes, which do no harm and which only can help. Does medication have an indication in management of colic? Well, according to this meta-analysis, look at a red arrow for drug. There is simply no place for medication in the management of colic. What can help is Lactobacillus reuteri in the exclusively breastfed infant and dietetic interventions. So pain relieving agents for infantile colic do not have an indication. There is no effect of proton pump inhibitors on crying and irritability in infants because crying is not a symptom of occult gastroesophageal reflux. So infants with reflux disease, they do cry a lot, but infants who only cry have only very rarely gastroesophageal reflux disease. And important to know is that proton pump inhibitors are not only not effective, they also are related to adverse effects, which are important. About 25 to 30% will develop small intestinal bacterial overgrowth, so which causes cramps and diarrhea and colic. And there are also nutritional consequences, decreased absorption of calcium, higher risk for iron deficiency, anemia. So multiple risk factors. Management with probiotics, these are the studies with Lactobacillus reuteri. As I said, in breastfed infants, positive studies. In unselected formula-fed infants, the study was negative. What is important also to know is that whatever functional gastrointestinal disorder you manage, there is a high incidence of placebo response, up to 50%. And in this study with Lactobacillus reuteri from the US, coming from the US, the placebo response was even higher, 66%. Probiotics are specific, and these are studies with Lactobacillus rhamnosus GG in infantile colic, 2 different studies which are negative. Nevertheless, Cochrane review concluded that at the one side, probiotics did not decrease infantile colic, but at the other side, they did decrease daily crying time, which is, I think, more important than decreasing colic. What matters for the mother is the duration of the crying time. What about dietary treatment? Allergy, in the older literature, extensive hydrolysates have been shown to be effective in the management of infantile colic. And this systematic review on hydrolysate just confirms that. Dietary management of infantile colic, systematic review, again, hydrolyzed protein may be beneficial. And this study from 3 years ago shows that a formula with symbiotics, probiotics, prebiotics, reduced lactose, partial hydrolysate decreases infantile colic. And again, the study from Italy, as we showed for the regurgitation, very rapid improvement within the first week of the dietary change. Other study from Italy showing a decrease of infantile colic within 1 week. Prevention might be more important than management, and there are studies showing that prophylactic use in the prevention of colic and functional constipation with an infant formula is visible, that you have a decrease of daily crying time of about 40 minutes. Few words about functional constipation. Again, the incidence about 10%, and constipation is related to the intake of cow's milk protein, because cow's milk protein may cause hard stool by the formation of calcium soaps. And so partial hydrolysates do decrease or increase the stool frequency and decrease the stool consistency, and bring the defecation rate of infants which are formula fed closer to the defecation rate of breastfed infants. Again, the study from Italy showing within 1 week improvement and not further improvement in the second week. So one of the main messages is that for functional gastrointestinal disorders in dietary treatment, the improvement, if there is improvement, it goes very fast. It's within the first week. What about palm oil? Well, palm oil could cause the formation of calcium soaps, and that's why infant formula milk may cause infant constipation. This paper concluded that there is insufficient evidence to suggest that palm oil should be avoided as a source of fat in infant formula for health reasons, because there was no clear evidence. On the other side, there is this meta-analysis suggesting that infants may benefit from a palm oil-free formula. So the debate is still open there. So what about for constipation management? You have to look, of course, for warning signs, and if they are present, you should look for appropriate referral. If they are not present, you could consider for the management with partial hydrolysate, prebiotics, probiotics, beta palmitate or other dietary. So it's not easy to make the difference between allergy and functional gastrointestinal disorders because the symptoms are quite similar. So what about the prevention of allergy? These are studies with partial hydrolysate showing that you have a decreased incidence of allergy symptoms in infants at risk if you feed them during the first 6 months with a partial hydrolysate. You see that you have at the red part of this slide with the partial hydrolysate, the full line, about 3 to 4% with allergic manifestations and about 10% with intact protein formula. And at the age of 3 years, you still have a difference of almost 50%. So together with this study of this meta-analysis from Hania Sajewska, showing you that with partial hydrolysate, you do have a prevention of cow's milk protein allergy up to, or allergic disease, sorry, up to the age of 3 years with about 50%. So together with a group of colleagues of you, we published this paper on prevention of allergic sensitization for the Middle East, where we said, of course, for a newborn, breastfeeding is the recommended way how to feed all infants. For exclusive breastfeeding, continue it for the first 4 to 6 months, partial breastfeeding, continue the breastfeeding, and assess for the allergy risk. And if there is no allergy risk done, then you should give the partial hydrolysate until the allergy management is done. If there is a positive history, partial hydrolysate is recommended. If there is no positive history, I think the choice is yours, because partial hydrolysate formula should be considered as an alternative for intact protein formula for every infant. Both have their concepts, have their advantages and disadvantages. That brings me to conclusion of my presentation. breastfeeding is of course the best to feed all infants, no doubt about that. But the healthcare professional has an important role in the management of functional gastrointestinal disorders. First of all, should always educate and reassure, and then bring into the context the nutritional management of the functional gastrointestinal disorder, and stay away from the medication which is not necessary and not recommended. So we are in the phase of submitting a paper about partial hydrolysates and prevention, and say clearly that with regards to partial hydrolysates, while no harm has been shown where they use, and some studies have suggested potential benefit as a decrease of atopic dermatitis, they can certainly be considered. Thank you for your attention. I will be happy to try to answer some questions.
All right, perfect. Thank you, Ivan, for this, again, wonderful presentation. We're going through the questions, but let me summarize what you have talked about. You have explained to us how common functional GI disorders in infants in general in different settings. You showed us that allergy is much less common than functional GI disorders in the breastfed babies, around 0.5%, while in the formula fed anywhere between 2 to 7%. And you told us also sometimes it's very difficult to try to tease out, is it a functional GI disorder or is it an allergy? You suggested to the use of the COMIS, the score, to help us in the diagnosis of the allergy. Also, you explained in the allergic infant, usually there is more than one organ system involved. Then you went in details about different functional GI disorders in infants, like the reflux and the colic and the constipation. In the reflux, I think you explained to us that the use of the AR formula can be very helpful in these infants, and some of them, they might improve like within a day or so, or sooner after that. In the colic, I love when you talked about the Middle East study and the perspective of the practicing physicians about the colic in the Middle East. And then you highlighted in a very beautiful way that colic is not only a problem now, it might have a long-term problem on the feeding and the growth and the other symptoms in the infant when they grow up to be teenagers or even adults. Then you explained to us about the reflux and to be cautious about using the medications, in particular the proton pump inhibitors, the PPI, and it might be associated with different side effects and the lack of effect of PPIs in treating simple reflux or simple crying. Then you talked about the probiotics in general and the Lactobacillus reuteri and its role in infantile colic management, and that several studies have shown that the use of L-reuteri in breastfed babies decreases the symptoms and enhance their well-being and decrease their functional GI disorders. And last but not least, the use of the palmitic oil. You showed us that the ESPGHAN does not recommend removing the palmitic oil from the infant formula.
Yes.
I think, yeah, perfect. I'm going to go through the questions, Ivan, and I will highlight for you the questions that I feel they are important or they were been asked by several people. Somebody asked you a very good question. Can you thicken the breast milk?
Well, I must laugh because in the first draft of the 2018 guidelines of NASBGHAN, someone had written that you could pump the milk of the mother and then thicken that and then feed it to the baby. So it's certainly technically possible to do. However, not many women like to pump the milk. So I think it's not really something to recommend to do. You could do it in theory, but in practice, I don't think that that's a good idea.
Okay, perfect. Another good question. Do you think the diet of the lactating mother might affect the functional GI disorders in an infant?
Well, there are no data on that. And the role of the diet of the mother, even for allergy, is discussed these days because the amounts of, for instance, cow's milk in mother's milk is so small that some colleagues doubt if it can cause really allergic disease. I think if a mother has a normal diversified diet, that then her intake is very unlikely to be related to functional gastrointestinal disorder. It's of course different if her diet is totally unbalanced, then her milk may contain too much of some aspects of her nutrition. We all know that if you eat a lot of onions, for instance, that may cause colic, but then you need to eat during days only onions. So a balanced diet is not related to functional gastrointestinal disorder for a breastfed infant.
Perfect. How about partial hydrolyzed formulas? Would you recommend them for functional GI disorders in infants? Whether
Yes,
it's
well,
formula with a pre or a probiotic?
Yeah, that's more or less the point I try to make, is that the guidelines for the management of allergy say that you need to put the child on an extensive hydrolysate for 2 to 4 weeks, but most of the guidelines speak about 4 weeks to have improvement. What comes out of the literature for functional gastrointestinal disorders is that for constipation and for colic, partial hydrolysate might be very effective, and you see the improvement within a couple of days. So the symptoms are not, if the symptoms are not clearly indicating allergy and you're in doubt, then you might try a partial hydrolysate for 1 week. And then if there is no improvement, then say, well, maybe it's allergy, and you switch to the extensive hydrolysate for the management of allergy. But if you think about a functional disorder, then partial hydrolysates are, I think, a good way how to manage them, except for the reflux, where you have to thicken the formula, which is more important.
So it's more probably in the colic constipation thing,
Yeah.
not reflux. Okay.
Yeah, but as some of the data show, is that I think at least half of the children with a functional disorder have a combination of different functional gastrointestinal disorders. And that's why it's not, we always discuss of them separately, but I think that in daily practice, it's not always possible or easy to know, is that infant now crying because he has a lot of reflux, or is that infant crying and because of the crying and the distress, does that make the infant reflux also? So it's not always very easy to know what is the primary problem. And therefore, I think that a solution which manage at the same time different functional gastrointestinal disorders is in daily practice quite useful.
Okay. We have a question, I think, from Iraq, Dr. Walid. Do you recommend the use of spasmolytics to treat colic?
Well, that goes back to the drugs and colic, and there the literature is quite clear. It does not help. So no, I do not recommend it.
You don't at all. Okay. Is there a difference between in functional GI disorder in the in the vaginal delivery versus C-section?
Well, that brings the whole discussion to the gastrointestinal microbiome and the microbiome and its relation to functional disorders. And it's clear that there is more and more literature, certainly for colic, that the microbiome plays a major role. And we all know that C-section is a reason to have an abnormal or dysbiosis, so an abnormal development of the microbiome. So there is a gut-brain crosstalking is certainly existing and is at this moment a very hot topic in research. And pain sensation in your bowel is related to your microbiome and how that communicates with your brain.
Yeah, and that brings the whole probiotics, prebiotic concept in the treatment or prevention. All right, here under question, Dr. Zainab, she's saying in extensively hydrolyzed formulas, can it cause constipation?
Well, in medicine, everything is possible, and I certainly have had also infants on extensive hydrolysates which seem to be constipated. But in theory, extensive hydrolysate causes greenies and rather liquid stools. So it's I think not many infants with extensive hydrolysates are constipated. It's mainly they have less frequent stools because a lot of these formulas is completely absorbed. Like breastfed infants, some breastfed infants have only one stools every 7 days, while others have 7 stools in 1 day. So I think the same is maybe true for extensive hydrolysate. While the majority of infants have frequent, relatively liquid stools, some infants have only one stool every 3-4 days, but that should probably not be regarded as constipation.
So in general, the extensively hydrolyzed infant, you expect him to have a softer, looser stools, and that can be normal, maybe due to the nature of the hyperosmolarity of the formula. If you see a constipated child, you have to think twice. Could it be something else if he's taking the extensively hydrolyzed?
Absolutely.
Oh, okay. All right. That's really nice. I think we can go on for hours. We have many interesting questions, but I think to stay within time, I'm going to give the microphone back to Tawfiq. And so we can move on to the second half of the webinar today. And if we have time at the very end, I think we can go back and have more questions. Thank you, Ivan.
Okay, thank you very much.
Thank you very much for the very kind presentation, of course. And thank you very much for Nestlé Nutrition Institute for giving me the possibility to be with us, with you today. It's an honor, of course, and I will try to give my perspective on this argument. The argument is quite controversial, since probiotics are really doing something in prevention in gastrointestinal or upper respiratory infection. And I will show you some data, and this will be not final indication, of course, because we need more scientific demonstration all of the probiotics and in particular of regulatory action on this. But first of all, presents the data on gastrointestinal and upper respiratory infection. I would like to underline how much the probiotics and lactobacillus species are able to interfere from the very, very early beginning of the life of the child or the infant with the immune system. This is a major point because probiotics can interfere with the microbiome and can give also indication to the cells of the immune system, giving also an increase in the tight junction stability among the epithelial cells, which decrease the gut permeability. And probiotics can act as a tolerogenic system, working on the dendritic cells, working on the development of regulatory T cells, which is absolutely important in the infancy. And again, we have indication that lactobacillus species are able to bind the toll-like receptors and give these tolerogenic signals from the very early beginning, drive the development of T regulation. This could be important, of course, in the prevention of allergy probably, but even in the prevention of This is quite relevant. I will show you that not all probiotics are the same. So we have to consider the strains which are really effective and the strain for which the efficacy is demonstrated. We know from the literature that there are some characterization of bicycle that Reuteri is presenting, and probably this is one of the system of signaling for this kind of species of probiotics interfere with the immunosystem and interfere even with the gut. So the real question is this one. So we need a perfect identikit of the right probiotics. So this Italian paper, in my opinion, is quite important since gave to us the possibility to understand 10 golden rules for a correct use. And one of which is quite important since probiotics should be live microorganisms that, when administered in adequate amounts, confer health benefit. This is a quite important point since we have a viability that is fundamental. On the other side, we have also a sort of specification of the claims which for that strain are particularly indicated. So this slide is absolutely important because the questions are always the same. Which probiotics we have to use or not to use? And if yes, how and for how long? Even in prevention of infection. So considering that probiotics have this strain-specific effect, you have to keep in mind that we have data and we have to consider the data of that specific individual strain, not as probiotic in general. It's a major point since in Italy we have on the market several hundreds of probiotics, different from the others. So you can imagine how putting together the data of efficacy, we can have no clear ideas regarding this. So again, we have to be very anchored to the strain specific effect. And for this, we have to consider that the literature is giving us a sort of indication. We have meta-analysis, we have a revision of the literature, of course, and by far the most commonly used probiotics are bacteria from the genus Lactobacillus or Bifidobacterium, and the yeast, the Saccharomyces boulardii. So we have also to consider viability, and this is a study from my university where they try to indicate in an in vitro model how some commercial probiotic population available in Italy are able to give some quantitative and qualitative aspects. But this in vitro study was really too stressful for the probiotics, and they were able to demonstrate that some spores were present in, in the gut, but not other probiotics in this in vitro gut. So we have to be able to keep in mind that probiotics, and this is one of the golden rules, may interfere with the microbiome, may be able to survive through the stomach and arrive to the gut. And these are the indications that we have from the literature, from the very the Reuteri and other specific strain of probiotics. So we go now to the idea that Reuteri can act in preventing gastrointestinal infection. And we have indication from the guidelines, such as this one, that in the upper part of the table, you can see that acute gastroenteritis treatment can give some indication with a strong recommendation for Lactobacillus GG and for Boulardii, and a weak recommendation for Reuteri. And this is what the new guidelines from the same society, of course, the ESPAN, was given us in the revision that was published during this year. So we have to consider that those are the probiotics which can work on this. Another point is again given from the position paper, from the position paper, excuse me, the position paper that these probiotics are really working. So the quality is quite low, but the recommendation are able. And so we can say that probiotics can have documented efficacy in the management of acute gastroenteritis. It's quite interesting to see, as in this paper, that probiotics for gastrointestinal disorders may have a different recommendation across the countries. Across Europe, where Rhamnosus GG, Boulardi, and Reuteri are recommended, and in other countries such as the United States, Latin America, the world, by different. Anyway, we have also indication that probiotics can have a moderate protective effect on antibiotic-associated. This is another point that is quite important, since we know that this point is quite peculiar. So we have also, we need again to consider that probiotics can act in this if they are able, of course, to survive the stomach transit and reach the gut. We have a paper, we had a paper last year that was quite important, and this paper with a lot of patients where administration of probiotics at the beginning of gastroenteritis was not able to modify the natural history of the episodes. And LGG was given to these children. However, in the revision paper by ESPGHAN, also this paper was put with the others, and again, the indication were positive for the recommendation of the probiotics in acute gastroenteritis. We can say that probably not all the probiotics are the same. Probably the timing of the administration is crucial. And also the dose of the probiotics is absolutely crucial. We have also indication from other papers, such as this one, that Lactobacillus reuteri administration with antimicrobial therapy, when antimicrobial therapy in this population in was used with a specific testing plus the administration reuteri, there was a significant effect on the recurrence of the diarrhea, on the duration of the episodes. In other words, given the right antibiotic using a rapid testing plus reuteri probiotics, given more protection, prevention in terms of episodes of diarrhea. And the authors of this paper say that probably the benefits was mediated through the formation of biofilms in the intestinal environment, as Lactobacillus species, as reuteri, are able to do. And reuteri is also able, this strain of reuteri is able to produce large amounts of reuterin, which is a molecule that can inhibit the growth of many different putative intestinal pathogens. So these are the mechanisms that probably are so important, and we have to keep in mind when we think about the probiotic action in prevention of gastrointestinal. And we have data, again, from the literature, which are historical if are less than 10 years old. But this study was performed given administration of calcium or another probiotics or Reuteri Protectis, shown that Protectis given a significant reduction of all diarrhea in this person, this patient, these children who were treated. And another paper that is quite important and regards also the upper respiratory infection is that administration of Lactobacillus reuteri reduced the incidence of common infection in daycare attending infants. So you can see from the slide that in yellow, the administration, the patient where Reuteri was administered had minor infection in terms of fever, in terms of diarrhea, less absence from daycare, less antibiotic prescription. These are the terms that we want to prescribe and indicate the effect of the probiotics. We go now in another very controversial issue. That is the effect on the probiotics and Reuteri, in particular in prevention of upper respiratory infection. We know that are so important and so heavy to manage for the health system of our country. Again, we have indication starting from the mechanism that probiotics are able to inhibit in some way the attachment of the virus on the host cell receptors in the intestine, the gut, but also in the respiratory apparatus. So they induce the mucosal regeneration, they induce the tight junction regeneration, and modulate, of course, the immune system. That is quite important and relevant action. And we see that probiotics has a lot of demonstrated action, we know in vitro probably, but demonstration of action of immunocells of the humans. And this is very, very important, of course, because it's the basis of the rationale for the administration of this. One of the major point is coming from this study where Gutierrez Castrillon was able to demonstrate the administration of Reuteri for 3 months, reduce the number of episodes of diarrhea. And this was the principal outcome. In these daycare attending children, there were less episodes of diarrhea. The duration of diarrhea episodes was reduced, and there was less intervention of this infection during the 3 months of the treatment. But from another point of view, during this intervention, there were also a significant reduction in the number of respiratory tract infections. This was a secondary outcome and was a surprise, but both at 3 months and then after the 3 months of follow-up, less reduction in the number of tract infection, which was absolutely cost-saving for the community. Of course, not all probiotics are the same. In the literature, we have a lot of indication that other probiotics, such as this Lactobacillus were not able to reduce the number of days absent from the child care in this day. So not all the probiotics are the same. The point, of course, is that we need meta-analysis, we need a review of the literature, which
Professor Diego, can you probably get closer to the microphone or something? we face some difficulty with hearing the sound, the microphone from your side.
Excuse me. We try in this way without my microphone. Excuse me.
That's better now.
And from the literature, we have some. Do you hear me now?
Yes.
The literature is showing that probably we have an effect from the probiotics in terms of reduction of infection. But the consideration that we have to do at the beginning is that the probiotics are so many, the timing is so different, the dose administered is so different that it's very difficult to have indication from systematic revision. Of course, we have also Cochrane revision that is not particularly recent. Again, there were more than 3,000 participants, including children, and probiotics gave better result than placebo in the number of participants experiencing episode of acute upper respiratory tract infection, in reducing the number of these infection, and in reducing the mean duration of an episode. These are indications that we need to keep in mind when we think about prevention of upper respiratory tract infection. Since the beneficial has a low quality of evidence, or very low sometimes, but the preventive effect was in favor of probiotics. And again, we have a very recent revision of the literature where again probiotics were showed different effect by species. And you can see that some strains were GG, Reuteri, Bifidobacterium lactis BB12 more effective than others. And so we have to keep in mind this indication when we think about the use of probiotics. Of course, we have also revisions that are, as this one, apparently confusing. Again, they say that there are not enough evidence for a systematic use of probiotic in the prevention of treatment of respiratory tract infection. And we have to think that, and this is the editorial that was quite important, that we have to treat almost 10 children to have a minimum of one prevention in one patient. This could appear a sort of very weak result. Again, we have to think that prophylaxis and prevention is quite important. And we have to think that upper respiratory tract infection are so common and so costly for the family and for the society. From this point, we have to consider this sort of study. These are a sort of economic issue of the impact of probiotic consumption on respiratory tract infection. This author from Canada shown that the use of probiotics, even though the results were not so clear, were able to save in that scenario a lot of money. And so this is a major point, of course, particularly if we consider that the higher relative benefits of the probiotic consumption in the reduction of respiratory tract infection were observed particularly in children less than 10 years old. In individuals we were living in community setting, in children who were not vaccinated against influenza. This is very important, of course. And I have also a particular point that this point that I like very much, to see that Lactobacillus species are able, as I show, to have effect on the immune system, but also vitamin D could be particularly relevant because they are both acting on the innate and adaptive immune system. And the interaction between Lactobacillus species from the very early beginning and vitamin D could help to reduce probably infection, to improve the quality, the response of the immune system. Since this point is quite important in the maturation of the immune system, in the prevention of the onset of allergic disease, and probably during infancy and childhood, why not, in the prevention of the upper respiratory infection. So, I'm in conclusion, of course, we have several hundreds of probiotics, and there are some effects, some claims which are different among all these probiotics. But we have to consider that some strain-specific effect could be particularly effective for some disease. And I'll try to show you how much is important to consider that some strain can prevent really infection of the gastrointestinal apparatus and also of the upper respiratory tract. So our situation is very important since probiotics can be a variable that can act from the very, very early beginning in select and drive the immune system of the child. If the mother can breastfeed, this is the gold standard, of course. Anyway, if you have to consider a formula, I will suggest a formula adding the probiotics from the very early beginning, since the microbiome is completely different and is a vulnerable place, particularly during the first weeks, the first months of life of infants. So the pediatrician perspective of the microbiome research, that is the point is very hot in this period, is that the infant gut microbiome is dynamic and vulnerable. The gut microbiome educates the infant immune system and may contribute to the host atopic and autoimmune disease susceptibility, but also the prevention of infection are probably so important. Nature and nurture both play significant roles in shaping the gut microbiome. And these are particularly important in some places because we can see that genetically diverse microbiome can correlate with the host metabolic fitness. And last but not least, certain probiotics are able to give protection for necrotizing enterocolitis. That is a major problem in the premature babies. And this is a major point, is in a model, an animal model study, but you can see that the species are facultative, particularly of microbiome, particularly in the first weeks, months of life of the infant. And it's the part where probably the natural history of some disease are present. This is very, very important. This is my final slide, where we can tell some words to the parent to decrease the risk. The risk of what? The risk of non-communicable disease. But I will say also the risk of infection. So we need to recommend moms a healthy and diverse diet, to have, if it's possible, babies born by vaginal delivery, breastfed for a variety of benefits, of course, recommend the daily use of moisturizing on infants, and introduce a variety of healthy, diverse food during the weaning period. That is very, very important to give a lot of vitamin, oligoelements, several things which could be very useful in protecting the child. And why not also introduce probiotics in the right timing, in the right dose, and in the right, of course, strain. Thank you very much for your attention.
Well, thank you very much, Professor Pirroni, for this bulk of information, or a flood of information, actually. I cannot summarize like what Dr. Migdadi did with Professor Van der Vlas, actually. You shed a light on very important subject, actually, which is new in some areas, like in Iraq. We are not using it very frequently, actually. It is a new subject for us, shedding the light on which and when and what to give probiotic is very important, because it should be used with the precautions. The major role of those probiotics is that they compete with the receptor of viruses and bacteria, and also they compete with the nutrition of those virus and bacteria is very important. I'm going to go through the questions. Actually, we have very important questions. What about one? Sorry. How would you recommend probiotic use in children with cancer during chemotherapy intake, and for how long?
This is a very, very good point, because we have to consider that probiotics are live microorganisms. So safety is the first issue, of course. And we have indication from the literature that rare cases of sepsis given also by some strain of probiotics are possible. This is particularly true, and I have in mind a couple of papers on Lactobacillus GG that gave this effect. So I will recommend to use with very
yes. And then after yes,
be very, very cautious in the use of probiotics in this sort of child. Very, very cautious.
Yes.
But on the other side, this is a major point. It's a major point, since we have to consider that probiotics are really working. And so for the healthy child, we have to need this indication. There are, and we have to use it because they are interfering really with the immune system. So safety first, and I will say that Reuterin is a safe probiotic. There are no indications in my mind about this.
Yes. So in patients who are receiving chemotherapy, you recommend that we use probiotic for them, especially after finishing their chemotherapy course, because this may affect the gut microbiota?
As I told before, this is an option that we have. And I will say we have to use the best strains, of course. And to be sure that this patient is not profoundly, deeply immunocompromised, because this is a contraindication of the use of the probiotics. But, of course,
yes.
I can imagine that chemotherapy can destroy everything. And so we need to give to the patient something from outside. I will say that probably we have to be very cautious, we have to be very prudent, we have to use this indication, but we have to be very strong in the follow-up of these patients.
Honestly speaking, Professor, I think there is overestimation of the benefit of probiotics in some situations, and we should be very careful, especially in severely immune-compromised patients who are receiving chemotherapeutic agents and others. So it should be not judicious, we should be careful. What about using of probiotic with antibiotic treatment? Is it with or soon after, or and for how long?
This is a good point because we have from the literature, from the analysis, the revision, also from the ESPGHAN, indication that some strains are working on antibiotic-associated diarrhea. And I will tell that probably we have to start the probiotics, and again we have to think about the right probiotics at the very beginning of the antibiotic treatment, and continue then the treatment with probiotics even after the stopping of the antibiotic therapy.
What about diarrhea due to parasitic infection when you are going to prescribe antiparasitic drugs? Like patients with parasitism, do you recommend to use also probiotic with them, or only for viral diarrhea and bacterial diarrhea?
I have no experience on this, to be honest, but as you told at the beginning, it's very important to consider that the probiotic can displace the receptor of some of these microorganisms. Why not also of the parasitic? So I'm particularly confident that the probiotic can offer an environment at the gut apparatus which can be protective. I was thinking about the tight junction, the immune system, the relationship among probiotics and the microbes which are present in the microbiome in the infant. So again, probiotic could be very useful in this.
And the other question is that, you know, that the gut microbiota is less diverse in products of cesarean section than in products of normal vaginal delivery. So do you recommend to give them, this is one of the questions, do you recommend to give babies immediately after birth probiotic to improve their gut microbiota?
This is a very good point. This is particularly true if the breastfeeding is not possible. Because we know from the literature, there are several papers that the microbiome is completely different in infants who are born by vaginal or cesarean section delivery. And again, the infants who are at higher risk are those who are born by cesarean section and have no breastfeeding. So particularly in these infants where there is no breastfeeding, there is a formula. I will suggest to use a formula with the addition of probiotics from the very, very early beginning.
One of the colleagues, I think they are mixing between prebiotics and probiotics. So he is asking use of yogurt versus probiotics. So what's your comment?
My comment is that the research is giving a lot of value and a lot of indication of which are the real factors which can modify the microbiome and give indication to the immune system. I really believe that probiotics and prebiotics can give a sort of fitness of the immune system of the infant. So they are so important. They are so important in the mother's milk, of course, that is a gold standard. And the research must try to find the best that is possible to do, of course, that require to modify the formula milk and make this formula more similar to the mother's milk. And indication from the literature is that adding probiotics and prebiotics to the milk, this could be beneficial in terms of shaping a right microbiome more similar to that one that is present in breastfed infants.
One difficult question, what about the role of probiotics in COVID-19?
This is a very difficult question. And since at the moment, you know, we were desperate in Italy 1 month ago. So everything was working and we have to try everything. But specifically, I have in mind a paper who was published just a few weeks ago in Frontiers in Immunology, and the title is Probiotics and COVID-19. And they gave an indication that probably the relationship between probiotics and microbiome in the gut and then in the other apparatus could be important. To be honest, I think that not only one factor, probiotic, could be helpful for a viral infection, a such important infection. I will add what is important in terms of improve the defense of the organism. Vitamin D, why not? Other factors, lactoferrin, I have published a couple of papers, point of view on lactoferrin, which is present in the colostrum, is present, of course, in the formula, and is present in breastfeed, could have particularly effect in the prevention of SARS viral attachment. But these are in vitro study, and we need probably something more on the field. Again, we need the indication from the literature. But your question is absolutely
the other point is that, you know, gut microbiota improves tolerability, and it makes tolerance better than for allergens. So there is one question about could probiotic addition to infants with food allergy or asthma modulate their immunity and get some benefits if you use them for those patients?
This is a very interesting point. And again, the point is absolutely controversial. And we know how many indications from both sides are present in the literature. We have indication, of course, from ESPGHAN, from EACI, that in the prevention probiotics, in the prevention of allergic disease, probiotics are not working. But we have also indication from the World Allergy Organization, and this revision was quite discussed, that in some cases we can have some prevention. Prevention of which of the allergic disease? Eczema, atopic dermatitis in particular, because atopic dermatitis appear within the first, we can say, 1 year of life. So indication are that it could be a weak protective effect given by probiotics. The timing is absolutely important, since the probiotic administration is working if this administration was done at the last trimester of the pregnancy, at the mother who was breastfeeding, at the infant during the first 6 months. This is the timing, the window of opportunity, even for probiotic administration, to have an indication. And if it's possible, I would like to underline how all these revisions are conditioned by the presence of not so many papers and so many different strains of probiotics. I would like to indicate that if we have a patient who is particularly at risk to develop allergy, I will try to use the probiotics from the very, very early beginning. even during the pregnancy.
I think regarding the reflex, the Ispagan and Naspagan, they don't recommend the use. One of the colleagues asking the role of probiotics in treatment and prevention of reflux and constipation. Do you have any comment?
There are no indication that probiotics are working. So we have to be honest in this, and these are not probably...
Yes. It was published last, I think it was the last recommendation by Ispagan and Naspagan at March 2018 that they have no rule actually in reflux disease in children. Is it safe to give probiotic continuously for 1 year or more for children? Any side effect of long treatment of probiotics? Is it better to give alternate or different strains or the same one?
This is a very, difficult question. Difficult question since I have no answer in this. I will say that probably we can start, and I'm quite sure that the very initial part of life of the infancy could have a strong indication from the same probiotics. The weaning is a particular period where all microbiome species are changing, and there are not so differences among infants. So probably we have to be the timing anchored some period. For me, it's difficult to think in terms of compliance, of course, in terms of economic cost of the use of probiotics for 1 year, for a couple of years. I will say that it's very important to use the probiotics when the administration was resulted effective. I told before, during the pregnancy, during the first 6 months of life of the infants. But then to have a periods, if we think about infection periods during the winter, which are the particularly difficult periods for, of course, the recurrence of these infections.
Actually, no parent will be compliant to give probiotic for so long period, for like 1 year even, and there is no clear indication for that. It seems that people are not going, as you said, in the rainy seasons, in the seasons of viral infections, one may suggest that. But for that long period, actually, one of the important questions, can we make use of prebiotics and probiotics as a standard now in all NICU, in neonatal intensive care units?
This is another very interesting point. And again, the safety point is primary. So we have to think that the premature is quite immunocompetent, not immunocompetent. Yes. So I have indication from the literature and also from some friends of mine that this could be a real problem. Very rare cases, but unfortunately quite severe, quite relevant. I would like also...
Thank you very much. Yes.
No,
yes,
just to
please.
say that probably, however,
yes,
the administration of these symbiotics could be so important. So we have to try and to find the right probiotics, which are also sure and safe, of course.
Thank you very much. I think we are running short of time. We have a lot of bulk of questions. Some of the colleagues, they were angry because you didn't answer them. I hope they can get the answer later on. I think, Dr. Tawfiq, we have a questionnaire to improve like a feedback for the next webinars. I am almost done.
Yes, exactly. We will be posting a few questions. If you don't mind, please fill it so that we probably get your feedbacks and improve the upcoming sessions. We know we have some technical issues with the sound, some things like that, but we hope we improve it within the coming webinars and sessions. And we take your feedback very seriously, and we work on it to improve the interaction together in the future. So I will just leave a closing comment for Professor, for everyone, if anyone has something to add, Professor Van den Plas, Professor Miqdady, Professor Diego, and yourself, Professor Khalaf, as well, to just close the session from your side as well with a final note to the attendees. Professor Van den Plas, if you can start. Probably you're on mute and we can't hear you.
Oops, now better.
Yeah.
Sorry. I did enjoy the webinar very much. I hope all the people who listened did as well. I think if we try to summarize it in one sentence, then not every child which present with symptoms is related to allergy. I think we focused on functional gastrointestinal disorders, showing how probiotics can help in preventing and treating some of those functional gastrointestinal disorders, and dietary treatment is important. And functional gastrointestinal disorders are much more frequent than cosmic protein allergy. So whenever the diagnosis is not clear allergy, and since the improvement on dietary treatment for a functional gastrointestinal disorders is very fast and within 1 week, think about that option, reassure the parents, try dietary treatment for a functional disorder, and if after 1 week there is no improvement or insufficient improvement, then think about cow's milk allergy. So a stepwise approach is, I think, the conclusion of this webinar.
Thank you so much. It was very engaging. Professor Miqdady, if you have a note to the audience, to the participants.
Thank you, Tawfiq. This was really a wonderful evening, a virtual nutrition forum, all the way from Belgium, Italy, Iraq, UAE, GCC countries, and other colleagues. I'm very pleased to see more than 1,300 people have joined us tonight. We have learned a lot today. In addition to what I summarized about Van den Plas, what Dr. Khalaf mentioned, Dr. Khalaf and Dr. Pironi taught us about the probiotics extensively, and even we talked about the coronavirus, which is the talk of the day, I guess. Very interesting talks, the role of the probiotics and this immune active effects of the pro, as well as maybe the prebiotics in different disorders, GI and non-GI. You talked about respiratory and other infections and their effects as well. I agree with Ivan and with the team that functional GI disorders are much more common than allergy, but allergy has to be kept in mind and thought of whenever we have a child with functional GI disorder, because the treatment, i.e. with the avoidance of these allergens, might have a long as well as a short-term effects. And many of these children, they might suffer for a long period of time if we don't recognize the allergy early. I think we have, you said you will have later after the webinar, you'll have some details about some of the questions that we were not able to answer during this time, but we have been talking for almost 2 hours now, and we really enjoyed it. I hope we will see all of you in person and not only virtual when this coronavirus slows down. I'm very pleased to see that Italy is recovering from this virus, and as well as the GCC countries and Belgium, and hopefully Iraq will recover from the virus very soon, inshallah.
Perfect. Professor Diego, if you have a final word.
Yes,
great.
I would
Yeah.
like to thank you again very much for giving me this opportunity. And I would like to remember to all of you that probiotics are live microorganisms that could interfere with the immune system. So this point of life are particularly relevant. So the interference with the microbiome from the very early beginning of life are so important. And this is particularly relevant. So this is an absolutely relevant point. And the other point is that we can use these probiotics also for other indication. And we need some more studies from the literature, again, regarding the strains and regarding the claims and indication. But we have to think that they can really work, they are really working and giving directions of indication to the immune system. Thank you very much for the invitation.
Perfect. Thanks a lot, Professor Khalaf. If you have a final statement that we can close with, and we'll be shooting the questionnaire for everyone to give us his thoughts as well.
At the end, I would like to thank the attendees from India and Southeast Asia to America. Actually, we have colleagues with USA with us from India. I would like to thank them. Being pediatrician, please always support breastfeeding. Thank you.
Perfect.
Absolutely.
A great closing statement. And from our side, we look forward to be with you in much more scientific activities, more engagement together with the different societies, with each and every respected medical and scientific society within the region and outside of the region, of course. And I thank you all for being there. It's a very engaging session. Probably I enjoyed every talk and every slide and everything that you shared. Thank you, Professor Van den Plas, Professor Diego, Professor Khalaf, Professor Mikdady, so much for your efforts and for your contribution today. And I hope you enjoyed yesterday as well and today too. So we'll be posting it's a quick poll for everyone to give us his feedback. And thank you so much for your time today and the attendees for being that late with us. We probably extended the time for a while, but it's good to have you with us. Thank you and see you very soon.